Morning and welcome, everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is February 22nd, 2023, and I'm pleased to call today's ACIP meeting to order, and I will now gavel us in. I'll turn it over to Dr. Melinda Wharton to begin with our purpose and our process this morning.
Thank you, Dr. Lee. Good morning, and welcome to the February 22nd through 24th, 2023 ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those of you who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When Dr. Lee opens the meeting for discussion, use the virtual hand raise function in Zoom to raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please keep your video off, except for our voting members when you're voting, and we ask that ACIP members turn on their video during votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we'll be holding one oral public comment period, which is scheduled for 2 p.m. Eastern Standard Time today, February 22nd. To create a fair and more efficient process for requesting to make an oral comment, we ask that people interested submit an online request in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2023-0007. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but those members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. That concludes my comments, Dr. Lee.
Thank you, Dr. Wharton. For the ACIP members, I will ask that you state your name, affiliation, and whether or not you have any conflicts of interest. I'm going to start to my left, Dr. Paling.
Good morning, Kathy Paling. I have no conflicts, and I am a professor of pediatrics, epidemiology, and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. Thank you.
Thank you. Dr. JYNNEOS.
Good morning. I'm Sybil JYNNEOS. I am an internist and pediatrician, associate professor of medicine and pediatrics at Warren Alpert Medical School of Brown University. I have no conflicts.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have a conflict of interest in that I am involved in a clinical trial with Takeda involving an investigational antiviral agent for cytomegalovirus. I am not involved in any of their vaccine projects. Thank you.
Thank you, Dr. Cotton. Dr. Long.
Good morning. I'm Sarah Long. I'm a pediatric infectious disease doctor in Philadelphia, professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you, Dr. Sanchez.
Good morning. I'm Pablo Sanchez. I'm a professor of pediatrics, neonatologist, and pediatric infectious diseases at the Nationwide Children's Hospital, The Ohio State University, and I have no conflict. Thank you.
Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strown Foundation based in Michigan, and I have no conflicts.
Thank you, Dr. Daly.
Good morning, Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and an associate professor of pediatrics, University of Colorado School of Medicine. No conflicts of interest.
Thank you, Ms. Bata.
Good morning, Lynn Bata. I am a public health nurse with the Minnesota Department of Health, functioning as a subject matter expert, and I have no conflicts.
Thank you, Dr. Lair.
Dr. Jamie Lair. I'm a family physician in private practice in Ithaca, New York, and I have no conflicts.
Thank you, Dr. Chen.
Good morning, Wilbur Chen, adult infectious disease physician trained, professor of medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you, Dr. Talbot.
Good morning, Kip Talbot, Associate Professor of Medicine and Health Policy. I'm an adult infectious disease doctor with no conflicts.
You know we have a lot of pediatricians in the room when people announce that they're adult infectious disease doctors. Dr. Bell.
Beth Bell, clinical professor, Department of Global Health, University of Washington, no conflicts.
Thank you, Dr. Bell. And Dr. Brooks?
Dr. Oliver Brooks, pediatrics by training, acting CEO and Chief Medical Officer, Watts Healthcare Corporation, Los Angeles, California. I have no conflicts. Good morning.
Morning, and thank you. And this is Grace Lee. I am a professor of pediatrics at Stanford University School of Medicine and CQO for Stanford Medicine Children's Health, and I have no conflicts. And with that, we should have quorum, so we are able to proceed for today. We will move on next to our ex officio and liaisons. I will announce the organization name, and then please indicate if you are present and your first and last name. First, we'll go to the Centers for Disease Control and Prevention.
President Jose Romero, Director, NCIRD.
Thank you, Dr. Romero. Centers for Medicare and Medicaid Services.
President Mary Beth Hance for CMS.
Thank you. Food and Drug Administration. We'll come back. Next, we have Health Resources and Services Administration.
LaSalle, present, here representing Division of Injury Compensation Programs. Thank you.
Thank you. Indian Health Service.
Good morning. President Matthew Clark, representing IHS.
Thank you. National Institutes of Health.
Good morning. John Bible from the National Institute of Allergy and Infectious Diseases.
Thank you. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. David Kim, OIDP, Office of the Assistant Secretary for Health.
Thank you. We'll move on to our liaison representatives, American Academy of Family Physicians.
Pamela G. Rockwell, present.
Thank you. American Academy of Pediatrics.
Sean O'Leary, representing AAP, present.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, editor of the AAP Red Book.
Thank you, Dr. Kimberlin. Next, we have the American Academy of Physician Assistants.
Good morning. Marie-Michelle Léger, AAPA, present.
Thank you. American College Health Association. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Rhoda Sperling, present.
Thank you. American College of Physicians.
Good morning. Jason Goldman, present.
Thank you. American Geriatric Society.
Ken Schmader here for AGS.
Thank you. America's Health Insurance Plans.
Jessica Grubb here, present.
Thank you. American Immunization Registry Association.
President, good morning. It's Rebecca Coyle representing ERA.
Morning. American Medical Association.
Sandra Freihofer representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle representing the ANA.
Thank you. American Osteopathic Association.
Good morning, Stan Grog, present.
Morning. American Pharmacists Association.
Good morning. This is Michael Hogue representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, good morning. This is Molly Howell representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
Richard Zimmerman, present.
Thank you. Association of State and Territorial Health Officials. Next, we'll move on to Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, present.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization. Move on to the Infectious Disease Society of America.
Good morning. Jim McCauley, present.
Thank you. International Society for Travel Medicine.
Present. Elizabeth Barnett.
Thank you. National Association of County and City Health Officials.
Matt Zahn, representing NACCHO, present.
If that was you, Dr. Zahn, we couldn't hear you very well. I'm not sure if that was you.
Can you hear me? This is Matt Zahn, representing NACCHO.
Thank you. We heard you now. National Association of Pediatric Nurse Practitioners.
Patsy Stinchfield, present.
Thank you. National Foundation for Infectious Diseases.
This is Bill Schaffner. Good morning. Medical Director of the NFID.
Morning. National Medical Association. Move on to the Pediatric Infectious Disease Society.
Good morning. This is Grant Paulson, present.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Monica Moser, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman for SAM.
Thank you. And Society for Healthcare Epidemiology of America.
Preeti Mehrotra, present.
I'm so sorry. Could you speak a little louder? I couldn't hear your name.
Preeti Mehrotra, present.
Thank you and welcome. Terrific. I'm just going to go back and ask if there's anybody, either ex officio members or liaison members who have since joined our roll call and would like to announce themselves.
Nicole Forbes, Public Health Agency of Canada, National Advisory Committee on Immunization, present.
Thank you. Any additional liaisons who would like to announce themselves? Okay, hearing no other individuals present, I think we will go ahead and, we are on time, Dr. Wharton, get started with today's meeting. So the first session of the day is the monkeypox vaccine session, and actually Dr. Wharton would like to make a few brief remarks at the opening of this session.
Thank you, Dr. Lee. In November 2021, ACIP unanimously voted in favor of JYNNEOS as an alternative to the other available vaccine for prevention of Mpox in persons with certain occupational risks of exposure. Today, ACIP is being asked to vote on an additional use of JYNNEOS vaccine for control of Mpox outbreaks. In 2022, a multinational outbreak of Mpox began with more than 30,000 cases in the United States. In response to this outbreak, JYNNEOS has been successfully used in accordance with recommendations in CDC's interim clinical considerations, and we've seen dramatic reduction in case counts. Today's vote will not change CDC's recommendations for use of JYNNEOS in the current outbreak, but represents an update to ACIP's recommendations, which were voted on in late 2021. And as you'll hear in Dr. Sanchez's introduction, we expect there will be additional decisions coming to ACIP for vote in future meetings. The recent outbreak has highlighted again the risks that infectious diseases can present to our communities, the importance of a robust public health response at the state and local level, the value of engaged partners and communities in responding to public health threats, and the impact that a vaccine can have in helping to bring an outbreak under control. With that, I will turn the floor back to you, Dr. Lee.
Thank you very much, Dr. Wharton. We will turn it over to Dr. Pablo Sanchez, who is the work group chair for the monkeypox vaccine. Dr. Sanchez, the floor is yours.
Good morning. Next slide. Okay. So this morning we'll be speaking and presenting on the Mpox vaccine from the work group, leading to a vote later today. So from a historical context, Mpox is rare, sometimes life-threatening infection that is endemic in parts of West and Central Africa. It is caused by the monkeypox virus, which is an orthopox virus. There are two clades. Clade 1 was previously known as the Congo Basin clade, while clade 2 was the previously known West African clade. It can spread from infected animals to people and then person to person, from respiratory secretions, from skin-to-skin contact with infected body fluids, such as fluid from lesions, as well as fomites from shared towels, clothing, and bedding. So the timeline of human Mpox events is shown on this slide. During 1970 to 2021, Mpox was known to be endemic in 9 African countries: Cameroon, Central African Republic, Côte d'Ivoire, Democratic Republic of Congo, Gabon, Liberia, Nigeria, Republic of Congo, and Sierra Leone. But as you know, during recent years, there's been a reemergence of human cases after decades of no reported cases. The first human case that was identified was in rural settings back in 1970. Subsequently, in 2003, there was a U.S. outbreak from pet prairie dogs. There were 47 cases identified. In 2017, there was an outbreak in Nigeria. And then subsequently in 2018, imported cases to the UK and Israel. There were 3 cases then. And 2019, imported cases again to UK, as well as Singapore. In 2021, there was imported human cases to UK and the United States. And then the multinational outbreak occurred in 2022. So the person-to-person spread has been seen with historical outbreaks in Africa. It's been associated with close skin-to-skin contact and contact with fomites. Zoonotic exposure was the cause, though, of most cases, with few secondary cases among close contact. In the U.S. outbreaks, in 2003, there were no secondary cases and no vaccination was offered. In 2021, again, there were no secondary cases, and ACAM 2000 was offered to some contacts. And then in 2022, the most recent outbreak, many secondary cases, and over 1 million doses of the JYNNEOS vaccine was administered. In 2021, ACIP had recommendation, as well as an orthopox virus vaccine vote, where the use of orthopox virus vaccine, the JYNNEOS, that was licensed in 2019 for pre-exposure vaccination of people at occupational risk for orthopox virus exposures. The JYNNEOS vaccine is a 2-dose series, subcutaneous administration, and recommendations were published in the MMWR in June 3rd, 2022. Currently, there is no ACIP recommendation for the use of JYNNEOS during outbreaks. So the current U.S. national Mpox vaccine strategy can be seen on this slide, with vaccination can occur before exposure to the Mpox virus, as well as post-exposure prophylaxis. The recommendations for vaccination before exposure include gay, bisexual, and other MSM, transgender, or non-binary people, including adolescents who fall into the aforementioned categories, who in the past 6 months have had new diagnosis of 1 or more sexually transmitted disease, more than 1 sexual partner, as well as people with the following who've had the following in the last 6 months: sex at commercial sex venues, sex in association with large public events in geographic areas where Mpox transmission is occurring, as well sexual partners of people with the above risks, people who anticipate experiencing above risks, and people with HIV or other causes of immunosuppression who've had recent or anticipate potential Mpox exposure. Among those with post-exposure prophylaxis recommended are people who are known contacts to someone with Mpox and has been identified by public health authorities. People who are aware that a recent sex partner within the past 14 days was diagnosed with Mpox. It's also recommended for gay, bisexual, or other MSM and transgender or non-binary people, including adolescents, who've had any of the following within the past 14 days: sex with multiple partners or group sex, sex at commercial sex venue, sex in association with an event, venue, or defined geographic area where Mpox transmission is occurring. The current U.S. strategy for vaccination with JYNNEOS during the current outbreak has been intradermal route is preferred, but subcutaneous route can be administered for persons aged 18 years of age or older. The subcutaneous route is recommended for persons aged less than 18 years. In the two-dose series, it is a two-dose series with the second dose administered 1 month after the first dose. So the current tentative timeline for ACIP discussions and votes is shown on this slide. So in February 2023, currently right now, Mpox, during Mpox outbreaks, we will be voting on the use of two-dose JYNNEOS for persons aged 18 years of age or greater. In June, we will be discussing the use of two-dose JYNNEOS for persons aged less than 18 years of age, and we will be presenting updates about vaccine effectiveness and safety. And then in October of 2023, there will be consideration for longer-term vaccination strategy for the two-dose JYNNEOS vaccine. It is important to know that the current U.S. Mpox vaccine strategy remains very active, and with populations at high risk should continue to be vaccinated. So the goal for today's meetings, there will be updates from the ongoing outbreak. The epidemiology will be presented by Sasha Ellington, vaccine effectiveness by Anna Chard, vaccine safety by Jonathan Duffy, the community engagement by Kevin Delaney, and equity and implementation by Rosalind Carter. We will discuss the use of the two-dose JYNNEOS subcutaneous route during Mpox outbreaks with an evidence to recommendations framework that will be presented by Agam Rao, and then subsequently an ACIP vote today. So the proposed wording for today's vote is that ACIP recommends the two-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of Mpox during an Mpox outbreak. It is important to state that an Mpox outbreak will be determined by public health authorities, and a single case may be considered an Mpox outbreak at the discretion of the public health authority. Just want to thank the work group, my co-ACIP member Beth Bell, as well as ex officio and liaison members, invited consultants with Inger Damon, Stuart Isaacs, who's been a huge help throughout, as well as clinician experts in STIs, HIV, pediatrics, and maternal vaccination, et cetera. Let's see. Other CDC contributors you can see. Brett Peterson has been absolutely wonderful throughout the whole JYNNEOS vaccine strategies. But I also want to point out laboratory response networks, infection control, special populations, vaccine safety, regulatory affairs, STIs and HIV, drug services, vaccine implementation, as well as our DOD liaison. But I also really want to give a shout out to our work group lead, Agam Rao, who's done a stupendous job in leading us through this to the current strategy and ultimately to the vote today. Thank you.
Thank you very much, Dr. Sanchez. And next, we'll move on to Dr. Sasha Ellington to speak about the epidemiology of monkeypox during the 2022 outbreak in the United States.
Good morning. I'm Sasha Ellington. I'm presenting on behalf of the Epidemiology Task Force of CDC's Mpox response, and I'll be talking about the epidemiology of the current outbreak. Next slide. First, I'm going to go over the general epidemiology of the current Mpox outbreak. Next slide. The first U.S. case associated with the current Mpox outbreak was identified in Massachusetts in May 2022. Cases were initially associated with travel. Since then, cases have been reported from all 50 states, D.C., and Puerto Rico. More than 30,000 cases have been reported to date. States with the most cases are California, New York, Texas, Florida, Georgia, and Illinois, all reporting more than 1,000 cases. Most cases have occurred in gay, bisexual, and other men who have sex with men, though cases have also been reported in men who have not reported sex with men, cisgender and transgender women, transgender men, gender diverse people, children, and teens. Next slide. The curve shows the epi curve of the U.S. cases, which peaked in August of 2022 and have declined substantially since. Currently, the 7-day moving average is 2 cases per day in the U.S. Next slide. As of February 8th, 95% of all cases reported have been among cisgender men, 2.9% among cisgender women, and combined 1.7% of cases have been among transgender men, transgender women, and gender diverse people. The age of people with Mpox ranges from 0, with a few cases reported in neonates, up to 89 years of age, and the median age is 34 years. Next slide. Overall, cases have primarily been reported among Black, Hispanic, and white persons, with nearly a third in each of these groups. You can see from the figure on the right that shows the distribution of race and ethnicity by month of the outbreak that at the start of the outbreak, about 45% of cases were among white persons, which decreased over time, while cases in Black or African American persons increased, and cases among Hispanic or Latino persons have remained fairly stable over the period of the outbreak. Next slide. In terms of clinical characteristics and outcomes among cases reported to date, 53% of cases with available data have been among people living with HIV, and 47% of cases have been among people who were HIV negative, though only 30% of cases reported had data on HIV status. Among cases with available data, more than half had rash reported on the genitals or perianal area, trunk or limbs, and head, face, or mouth, and about a quarter had rash on the palms or soles of the feet. 7.7% of people with Mpox have been hospitalized, and there have been 32 Mpox-associated deaths reported, representing 0.1% of cases. Deaths have occurred primarily in severely immunocompromised persons. Next slide. During the current outbreak, Mpox has been primarily spread through sexual or close intimate contact. Other routes of transmission have also been reported, including household transmission, through injury with a contaminated sharp instrument in a clinical setting, through piercing and tattooing, and there have been a couple of cases of perinatal transmission from an infected mother to an infant around the time of delivery. Current evidence suggests that some people can spread Mpox virus to others 1 to 4 days before they become symptomatic. However, there is no evidence that people who never develop symptoms have spread the virus to others. Next slide. This table summarizes what specimens Mpox has been detected in by PCR, whether replication-competent viruses has been detected, and whether each exposure source has been associated with transmission. Replication-competent virus has been detected or isolated in skin lesions, oropharyngeal swabs, anal-rectal swabs, semen, urine, and ocular fluid. Mpox has been transmitted from skin-to-skin contact, oral contact, and from a contaminated sharp. Transmission via exposure to some sources, such as semen, can be particularly challenging to assess, since exposure typically occurs during close intimate contact that also includes skin-to-skin contact. For this reason, many exposure sources listed here have insufficient data to definitively conclude they are a source of infection. Next slide. As previously mentioned, 95% of cases of Mpox have been reported among cisgender men, and cases have occurred primarily among gay, bisexual, and other men who have sex with men. Among the cases reported in men with data on recent sexual history, 75% reported sexual or close intimate contact with a man in the 3 weeks preceding symptom onset. However, in 25% of cases among men, no recent male-to-male sexual contact was reported. Over time, we have observed the percentage of cases in men that had recent male-to-male sexual contact has declined from over 80% initially to about 60%. But we've also observed increases in the missingness of sexual contact data, which may contribute at least partially to this decline. Next slide. So next, I want to highlight the epidemiology of Mpox in a few specific populations that have been less affected overall, but the characteristics of these cases have contributed to our overall understanding of the epidemiology. Next slide. First, I want to present data from a publication that came out earlier this year reporting on cases in cisgender women. About 3% of the Mpox cases have been in cisgender women. Median age of cases in this group is 32 years, ranging from 15 to 89. 44% of cases in cisgender women were in Black, non-Hispanic women, 25% in white, non-Hispanic women, and 23% in Hispanic or Latino women. Of those with available data on HIV status, 8% of cases in cisgender women were HIV positive and 92% were HIV negative. And while the data were only available for 22% of cases among cisgender women, this is markedly lower than the percent of total cases that were HIV positive, which was 53% as previously presented. 71% of cases among cisgender women reported a recent sexual or close intimate partner. Next slide. So the same publication also reported on cases in pregnant people. From May to November, 21 cases of Mpox were reported during pregnancy, and 2 cases were reported in a recently pregnant person, which was defined as within 3 weeks of pregnancy. Among those with exposure data, which were 12, 9 reported sexual contact and 3 reported household contact to a person with Mpox. Pregnant people had similar signs and symptoms of Mpox as those among non-pregnant people. 4 cases among pregnant people had genital lesions during the pregnancy, but none had lesions at the time of delivery. Tecovirimat was provided to 48% of cases during pregnancy with no adverse events reported, and none of the pregnant cases received post-exposure prophylaxis with JYNNEOS. Outcomes reported to date have included 4 hospitalizations of pregnant people for Mpox indications, and all were discharged while still pregnant. No pregnant cases required intensive care, intubation, or unplanned delivery. To date, pregnancy outcomes have been reported among 3 patients. 2 were uncomplicated live births with no transmission to the infant, and 1 pregnancy resulted in a first trimester spontaneous abortion. 2 recently pregnant persons experienced symptoms within 3 days of delivery, and their newborns developed lesions within a week. The exact timing of transmission for these infant cases is unknown. Next slide. In another recent report, we assessed characteristics of Mpox cases among 466 transgender and gender diverse persons. In this analysis, 43% were transgender women, 42% were gender diverse, and 15% were transgender men. Of the gender diverse persons, 96% were assigned male sex at birth. The median age of the transgender and gender diverse persons with Mpox was 32 years and ranged from 18 to 71 years. 28% of transgender and gender diverse persons with Mpox were Black, 28% were white, and 37% were Hispanic or Latino. About half of the transgender and gender diverse persons with Mpox were HIV positive, which is similar to the percentage observed among all persons with Mpox. 84% of transgender and gender diverse persons with Mpox reported recent sexual or close intimate partner contact. Next slide. In another recent report of 83 cases in children from May to September of 2022, there were 16 cases in children aged 0 to 4 years, 12 cases in children aged 5 to 12, and 55 cases in children 13 to 17. Adolescents aged 13 to 17 were overwhelmingly male and primarily had sexual exposures, mirroring the epidemiology of cases overall. While in younger children, cases were more evenly divided by sex and were associated with household contact, frequently from an infected caregiver. While these findings are from a report analyzing data through September, we have continued to investigate cases in children, particularly younger children, and findings have been similar. Next slide. So lastly, I will present briefly on the number of vaccine doses administered to date and compare the distribution of race and ethnicity among cases of Mpox reported to CDC to the distribution among vaccine recipients. Next slide. As of February 7th, 2023, 1,185,907 doses were administered. This includes 732,725 first doses. The blue bars represent first doses and the green bars represent second doses. As you can see, both first doses and overall doses administered peaked in August, at the same time when Mpox cases reported to CDC peaked. Doses administered has declined substantially since August. In the first week of February, there were 1,314 first doses and 1,243 second doses administered. Next slide. So on this slide, we show the overall distribution by race and ethnicity among Mpox cases on the left and the distribution of race and ethnicity among first dose vaccine recipients on the right. This is cumulative over the course of the current outbreak. Starting from the bottom, you can see that while 1/3 of Mpox cases occurred among Black or African American persons, just 13% of first dose vaccine recipients were Black or African American. And while 31% of Mpox cases were among Hispanic or Latino persons, just 22% of first dose vaccine recipients were Hispanic or Latino. Additionally, 29% of Mpox cases were among white persons, while 52% of first dose vaccine recipients were among white persons. So we see some substantial differences by race and ethnicity when comparing those who have been infected versus those receiving vaccine. And thank you. That is my final slide.
Thank you. Thank you. We'll pause for a moment and just ask if any of the members have questions they'd like to raise or clarifications. Dr. Paling.
So, Dr. Ellington, thank you for this great presentation. The question I have is, there's clearly a disparity in cases and in administration of vaccines. And have we looked into areas where there's less disparity to understand how to effectively make sure everybody at risk has the availability to receive the vaccine? Or do you have any insights? Thank you.
Thanks. Yes, we are continuing to investigate the disparities between cases and vaccinations and looking at rates among both cases and vaccine recipients. And we have noted significant disparities not only in the absolute numbers but in the rates when looking at the estimated populations that are affected. I think there will be a presentation later at the end that will focus on equity and implementation, where that will answer your question more completely.
Thank you. I see Ms. Hayes has her hand raised.
Yes, thank you. Carol Hayes with the American College of Nurse Midwives. I have a question. Your slide indicated that there were 21 pregnant people who contracted the disease, but you only gave the outcome for 3 individuals. Do you have any data on the 18 others?
So at the time of the analysis, those 18 pregnant people were still pregnant. So there is continued follow-up. There are continuing to be follow-up, and outcomes will be reported as they become available, but they remain pregnant.
Okay, great. And my next question is, did the individual who had a miscarriage, a spontaneous abortion, receive medical treatment with the Tacrolimus?
I'm sorry, I do not have the details of that individual case at this time, but we can follow up with that.
Great. Thank you very much.
Thank you. Ms. Bata?
Thank you for this presentation. I appreciate the review of the EPI. You talked about none of the recently pregnant women receiving the JYNNEOS. Was that because it just wasn't indicated in terms of, or it wasn't licensed or authorized, or was that refusal?
So we have documented cases of JYNNEOS being offered and pregnant persons declining, but not in all circumstances. But it has been offered, but none of the pregnant persons received the vaccine.
Thank you.
Thank you. Dr. Long?
Yes, thank you. Your use of the word recently pregnant, you were talking about outcomes of individuals who develop disease or lesions within 3 days of delivery. So I thought recently pregnant meant they're no longer pregnant, but now when you answered Dr. Bata's question, I'm not so sure they weren't in early pregnancy. So can you clarify that? And the other thing is, did any woman have lesions around the time of pregnancy? And did the work group discuss whether there would be advantage of cesarean delivery?
So yes, the definition of recently pregnant was within 3 weeks of the pregnancy completing. So there were 2 cases where the pregnant person developed lesions actually around the the time of delivery, several days after delivery in those two cases. And I'm sorry, what was the second part of your question?
You said recently pregnant to answer Dr. Botta's question about vaccination. So you're talking again about postpartum women refused vaccination?
No, I'm sorry. I think I must have misspoke. For the previous question, it was a pregnant person. None of the pregnant persons who were offered vaccine accepted vaccine.
Thank you.
Yeah.
And then there was a question. What is CDC guidance?
Thank you. And just one last clarification question for me, which is, could you comment if any of the deaths were seen or observed in pediatric cases?
None of the deaths observed to date have been seen in pediatric cases.
Thank you very much. Ms. McNally.
Thank you. Of the 1 million doses administered, can you talk about who the vaccinators were? Is there a breakdown of that information?
I think that will be covered in a follow-up presentation this morning.
Wonderful. Thank you, everyone. Next, we'll move on to Dr. Anna Chard, who will speak about JYNNEOS vaccine effectiveness.
Good morning. I am presenting on JYNNEOS vaccine effectiveness on behalf of the Vaccine Task Force of CDC's Mpox response. Next slide. The efficacy of JYNNEOS vaccine against Mpox has been inferred from animal and immunogenicity studies, but it has never been demonstrated in clinical trials. Additionally, prior to the multinational outbreak, there were no real-world effectiveness estimates for JYNNEOS against Mpox disease. Therefore, we identified the following key questions related to vaccine effectiveness. What is the effectiveness of JYNNEOS vaccine against Mpox disease, both for partial or 1 dose and full or 2-dose vaccination? On August 9th, 2022, an emergency use authorization was issued for intradermal administration in a 2-dose series to increase vaccine supply. So we wanted to examine differences in VE by route of administration, namely doses administered subcutaneously, intradermally, or heterologously. Because the population most at risk for Mpox disease are also at higher risk of immunocompromising conditions such as HIV, it is important to understand if there are differences in VE among persons with immunocompromising conditions. And lastly, the duration of protection conferred by JYNNEOS vaccine is unknown. In this presentation, we will present evidence for the first 2 questions, though evidence remains limited regarding VE among persons with immunocompromising conditions and the duration of protection from JYNNEOS vaccine. Next slide, please. The organization of the presentation is as follows. First, we will review a study on vaccine performance, which compares the incidence of Mpox among unvaccinated persons versus persons receiving 1 or more JYNNEOS doses. Then we will review a study conducted by the New York City Department of Health examining VE of JYNNEOS administered as post-exposure prophylaxis, or PEP, against Mpox disease. And last, we will review 4 slides on vaccine effectiveness of JYNNEOS given as pre-exposure prophylaxis, or PrEP, including a cohort study from Israel that estimated the effectiveness of a single dose of Mpox vaccine among males eligible for vaccination, a case control study that estimated the effectiveness of 1 and 2 doses of JYNNEOS against Mpox disease in the US using electronic medical records, interim estimates from a case control study estimating the effectiveness of 2 doses of JYNNEOS against Mpox disease in 12 US jurisdictions, and finally, preliminary estimates from a case control study from New York State Department of Health estimating VE of 1 and 2 doses of JYNNEOS against Mpox disease in New York State. Next slide. And next slide, please. For this analysis, investigators used surveillance data from confirmed and probable Mpox cases, vaccine administration data ascertained from interviews and immunization registries, and jurisdiction-specific estimates of the vaccine-eligible population to compare Mpox incidence among persons who are unvaccinated and those who had received either 1 or 2 JYNNEOS doses. There were 9,544 reported Mpox cases among men aged 18 to 49 years from 43 U.S. jurisdictions during the analysis period, which was July 31st to October 1st, 2022. Investigators estimated weekly Mpox incidence for persons with partial and full vaccination and persons eligible but unvaccinated. The incidence rate ratio was calculated using negative binomial regression controlling for week. Next slide. The graph on the left shows Mpox incidence by vaccination status. Unvaccinated is in red, partially vaccinated is in light blue, and fully vaccinated is in dark blue. Mpox incidence among unvaccinated individuals was 7.4 times as high as persons receiving 1 dose of JYNNEOS vaccine, and Mpox incidence among unvaccinated individuals was 9.6 times as high as persons receiving 2 doses of JYNNEOS vaccine. There was no difference observed in vaccine performance between subcutaneous and intradermal administration. Next slide, please. Next slide. The New York City Department of Health examined VE of JYNNEOS administered as PEP using a cohort evaluation of individuals 18 and older identified through contact investigations to a case patient with Mpox between March 22nd and August 24th, 2022. PEP was defined as receiving the first dose of JYNNEOS within 14 days of exposure and prior to symptom onset. Case patients were defined as exposed individuals who developed symptom onset within 21 days of exposure and had laboratory confirmation of Mpox. VE was 77% among individuals who received PEP less than 14 days after their last exposure, and 79% among individuals who received PEP less than 14 days after their first exposure. Next slide, please. And next slide. Investigators in Israel evaluated the real-world effectiveness of a single subcutaneous dose of MVABN, which uses the trade name JYNNEOS in the U.S. This was a retrospective observational cohort study based on data obtained from electronic health records from a single integrated healthcare organization in Israel. The cohort included 2,054 men eligible for vaccination on July 31st, 2022, when the vaccination campaign began, who had completed at least 90 days of follow-up. Eligibility criteria is listed in the footnote on this slide. The time period for this analysis spanned July 31st to December 25th, 2022, such that all participants were followed for 90 to 120 days after cohort entry. VE was estimated using Cox proportional hazards regression with vaccination status as a time-varying covariate. And the model adjusted for socio-demographic and clinical risk factors. Next slide, please. The graph on the right shows cumulative hazard of Mpox infection during the follow-up period. As before, unvaccinated individuals are in red and vaccinated individuals are in light blue. During July 31st to December 25th, 2022, there were 5 cases among vaccinated individuals and 16 cases among unvaccinated individuals, and the adjusted single-dose vaccine effectiveness was 86%. Next slide. In the EPIC Cosmos case control study, we used data from EPIC's electronic health record platform called Cosmos, which includes records from over 169 million patients across the US. This was a case control design in which cases were defined as patients with an Mpox diagnosis or a positive orthopox virus or positive Mpox virus laboratory result from our study period, which was August 15th to October 29th, 2022. Controls were defined as patients with an incident HIV diagnosis or HIV PrEP prescription during the same study period and was determined based on ASPR vaccine distribution guidance. VE was estimated using conditional logistic regression models, adjusting for a priori specified confounders, and we also stratified the analysis to examine full and partial VE by route of administration and immunocompromised status. Next slide, please. Here we show adjusted VE for full vaccination on the top half of the table and VE for partial vaccination on the bottom half. Adjusted VE was 66% for full vaccination and 36% for partial vaccination. Among individuals with no immunocompromising conditions, VE was 76% for those fully vaccinated and 41% for those partially vaccinated. Although we controlled for immunocompromising conditions in our analysis, we could not estimate VE among this population because vaccine coverage was low. Less than 1% of immunocompromised individuals were fully vaccinated. When examining VE by route of administration, very few patients were fully vaccinated with 2 subcutaneous doses or 2 intradermal doses. So the 95% confidence intervals are wide, but the point estimates are similar to the overall estimate. For fully vaccinated persons with heterologous administration routes, VE was 75%, demonstrating that 2 doses confers protection regardless of the route of vaccine administration. Next slide, please. The multi-jurisdictional case control study is currently underway. This study examines vaccine effectiveness among men aged 18 to 49 who have sex with men and live in 12 U.S. jurisdictions. Cases are identified through the jurisdiction's probable and confirmed Mpox case lists. Controls are selected from healthcare settings providing HIV PrEP or from sexually transmitted infection clinics. Cases are frequency matched to controls based on time point within 4 weeks of clinic attendance and jurisdiction. Jurisdiction staff members collect data on participants' demographics, exposure history, and vaccination history using electronic surveys, and vaccination status of enrolled participants is confirmed using state immunization registries. VE is estimated using multivariable logistic regression with the random intercept for jurisdiction and adjusted for a priori specified confounders. Next slide. Again, these are interim results as data collection is still underway. Results indicate that vaccine effectiveness was 76% for full vaccination. Among those without immunocompromising conditions, vaccine effectiveness was 90% for full vaccination. At this interim stage, there were few individuals with partial vaccination or with immunocompromising conditions. Therefore, data are not sufficiently powered to generate estimates for these strata. Next slide, please. Lastly, I will share preliminary estimates from a case control study in New York State. Investigators linked case surveillance data to the immunization registry. Cases were adult male Mpox cases diagnosed during July 24th to October 31st, 2022. Controls were adult male rectal gonorrhea or primary syphilis cases during the same time period. Cases and controls were matched on week of diagnosis, and VE was estimated using conditional logistic regression. VE was 68% for partial vaccination and 89% for full vaccination. Next slide, please. Next. In summary, the existing body of evidence for VE of JYNNEOS against Mpox disease ranges from 66 to 83% for full vaccination, shown at the top of the forest plot, and 36 to 86% for partial vaccination, shown at the bottom of the forest plot. Next slide. This evidence indicates that the JYNNEOS vaccine is effective at reducing the risk of Mpox disease. Protection is provided by both 1 and 2 doses of JYNNEOS vaccine, but the highest protection is provided by 2 vaccine doses, regardless of administration route. Further research is needed to assess whether immunocompromised status modulates vaccine effectiveness. Due to small numbers in this population across studies, we were insufficiently powered to generate VE estimates among immunocompromised individuals. Additionally, because of a decline in Mpox cases and the limited follow-up period from studies to date, further research is needed to assess the duration of protection conferred by JYNNEOS vaccination. Next slide. I'd like to thank the individuals shown on this slide, and I'm happy to take questions.
Thank you. This presentation is now open for questions. Dr. Paling.
So Dr. Chart, I just want to say a huge thank you to you and the huge team that did this work. This is an incredible amount of information and is timely and important, and I just have tremendous gratitude for pulling so much information together quickly.
Thank you so much.
Thank you. Dr. Daly?
Yeah, I would second that wholeheartedly. So my question is related to the fairly disparate findings about sort of obvious question, but it's a pretty big difference in estimates of single dose coverage. And I have a sort of related question, which is, can you remind us what the dose of subcutaneous versus IM is, and whether there's concern about if a subcutaneous dose is given a little too deep, then it's less immunogenic? And you can either take those as separate or related questions, but I'm just curious. Thank you.
Thank you for that question. Subcutaneous is 0.5 milliliters, and intradermal is 0.1. And regarding your question about if the vaccine is delivered a little too deeply, how that affects vaccine effectiveness, is that the second part of your question? We don't have data to answer that question at this time, unfortunately.
And then maybe back to the question about single dose. Yes. How effective is a single dose, or sort of, and those differences in estimates? Thanks.
Yes, so there are very wide range in estimates for partial vaccination, and you can note that some of the confidence intervals are also very wide, and so they often they overlap. The studies that investigated partial vaccination, they all have very different designs and they're among very different populations. So I think that that contributes to the range in VE estimates for partial vaccination. But when you look at the body of evidence in the studies that investigate both full and partial vaccination, across the board we see that full vaccination provides higher protection than partial vaccination when you're comparing apples to apples.
Thank you, Dr. Long.
It's a question about subcutaneous versus intradermal. I see in the background material and what you've already said that intradermal is preferred for adults, but we're going to be voting on subcutaneous, and it looked like intradermal was a little bit higher or a little bit more effective or a little higher antibodies. Was that statistically significant difference between intradermal and subcutaneous? Is the first question.
Thank you for that question. No, there was no statistically significant difference between the two administration routes, though the data were very limited to be very powered for that.
Okay, so we'll see later whether you're going to prefer intradermal because very few people can administer anything intradermal anymore. It's very difficult to get the right spot. So I assume we'll discuss that later.
Yeah, sorry, this is Agam Rao. I can just jump in on that. So intradermal is currently, intradermal early on was the recommended, was definitely the recommended route because of the shortage of the vaccine available. There is a lot more vaccine available now. Intradermal remains the preferred, but clinicians and health departments for specific patients can request, can administer the vaccine subcutaneously. The route of administration should not be a reason that someone is not vaccinated. So there is more of that permissiveness now that there is much more vaccine available. And these are just for outbreak settings where we would say that this particular outbreak, that intradermal is being preferred because of the shortage.
May I ask one clarifying question, which is, I believe it's slide 52, I'm not 100% sure, but the EPIC Cosmos case control study, sorry. I just wanted to clarify, one more time. So I saw the estimate for no immunocompromising conditions, but you did not take a look at the 40 or so people on the bottom, or the 13 people on top who were immunocompromised. And my question was, did you take a look at the vaccine effectiveness estimates? How did you define immunocompromised? Does that include well-controlled HIV or only poorly controlled HIV?
So we did look preliminarily at VE among immunocompromised individuals, but vaccine coverage, particularly full vaccine coverage among immunocompromised individuals, was so low that we couldn't generate an estimate among this population. And immunocompromising codes, we have a list that we'd be happy to share. It's very long, but it includes people with different organ transplants, on different, taking different pharmaceutical medications, and HIV diagnosis codes. But we did not look, for example, at CD4 counts to look at how well controlled someone with HIV, what their levels were.
Okay. Yeah, it might be helpful for the future to capture that information given the epidemiology described in the very beginning. So as you're able to, that would be wonderful. And then also just one more comment, but not really a question, is as you collect more information on intradermal versus sub-Q administration, it would actually also be really useful, if it's possible, to take a look at that combined with full versus partial vaccination to understand if there's any differential impact in the setting of an outbreak, if there's a preference for one or the other. I recognize that the numbers are incredibly low, but as we accumulate numbers, it might be possible to take a look at that.
Great, thank you.
Thank you. Any other questions? Okay, next we'll move on to Dr. Jonathan Duffy, who will be speaking about vaccine safety monitoring during the 2022 monkeypox outbreak.
Thank you. An MMWR report about JYNNEOS vaccine safety monitoring was published that included data collected through October of 2022. Today's presentation will include data through January of 2023. Next. This presentation includes information collected using 3 surveillance systems. First is the Vaccine Adverse Event Reporting System, also called VAERS, which is the National Passive Reporting System. Second is the Vaccine Safety Data Link, which performs medical visit-based active surveillance for pre-specified adverse events of special interest in a population of more than 10 million people. Third, vSafe, which is a smartphone-based system that uses text messaging to initiate web-based survey monitoring for adverse events. And then fourth, adverse event data was also collected as part of single-patient emergency investigational new drug procedures for persons aged less than 18 years, vaccinated before the JYNNEOS emergency use authorization was issued that allowed administration for that age group. Next. First, I'll provide an overview of the VAERS findings. Next. VAERS is the National Passive Surveillance System for adverse events after vaccination. VAERS accepts reports from healthcare providers, vaccine manufacturers, and the public. VAERS collects data on any adverse event following vaccination, be it coincidental or truly caused by a vaccine. The report of an adverse event to VAERS is not documentation that a vaccine caused the event. Next. The FDA issued an emergency use authorization for JYNNEOS on August 9th, 2022 that required reporting to VAERS for vaccine administration errors, whether or not associated with an adverse event, serious adverse events, irrespective of attribution to vaccination. Next slide, please. Cases of cardiac events, including myocarditis and pericarditis, and cases of thromboembolic events and neurovascular events. Next slide. The analysis presented here includes VAERS reports received and processed by January 20th, 2023. Adverse event reporting rates were calculated by dividing the number of VAERS reports by the number of vaccine doses administered in the United States. 698,188 people received dose 1 during this period, and there were more than 1.1 million total doses administered. Next. VAERS received 1,817 reports after JYNNEOS. Most of these reports were from males, adults aged 18 to 64 years, and for JYNNEOS given alone without other vaccines on the same day. Most reports were about dose 1. The most common route of administration was intradermal, followed by subcutaneous. Intramuscular administration was also reported, most of which were reported in error in the route of administration. Next. Vaccine administration errors were the subject of 50% of all JYNNEOS VAERS reports. Of these, 96% did not report an adverse health event. Vaccine administration errors have been reported for JYNNEOS about 3 times more often with intradermal compared to subcutaneous administration. The most common issue reported with intradermal administration has been absence of a wheal without vaccine leakage. CDC's interim clinical considerations for use of JYNNEOS state that absence of a wheal without vaccine leakage may be counted as valid administration. Next. After excluding reports of vaccine administration errors alone, adverse health events were reported to VAERS at a similar rate for subcutaneous and intradermal administration. The most common types of events differed slightly by route of administration. Overall, the most common adverse health events reported to VAERS for adults were consistent with those reported in pre-licensure clinical trials. Next. So now to talk about serious adverse events. A serious adverse event is defined as a report of the occurrence of any of the following: death, a life-threatening event, hospitalization, a persistent or significant incapacity, a birth defect, or another important medical event. Next. About 1% of reports to VAERS after JYNNEOS were classified as serious. Serious adverse events were reported at a rate of 22 reports per million doses administered. The serious adverse events reported to VAERS after JYNNEOS are listed on this slide. Not all adverse events that occur after vaccination are caused by the vaccine. 2 deaths were reported to VAERS after JYNNEOS administration. The local medical examiners determined and reported the causes of death in these cases to be drowning and cocaine toxicity. Hospitalization for myocarditis or pericarditis were the most commonly reported serious adverse events, and these conditions will be discussed in detail next. The single cases of the other conditions reported here do not suggest safety signals for any of these conditions. Next. So I will now discuss myocarditis and pericarditis findings in more detail. Next. Myocarditis and pericarditis have occurred following either primary vaccination or revaccination with live vaccinia smallpox vaccines in the past. The mechanism is poorly understood, and it was unknown whether persons who received JYNNEOS might experience myocarditis or pericarditis. In this epidemiologic analysis, the cases have been classified into 2 groups. First is myocarditis with or without pericarditis, and the second group is acute pericarditis alone. Their surveillance risk interval was defined as symptom onset within 30 days after vaccination. Next. This slide shows the number of myocarditis cases and rates observed after JYNNEOS based on reports to VAERS and active surveillance in the vaccine safety data link. In VAERS, there were 2 cases reported after dose 1 for a rate of 2.75 cases per million persons vaccinated. 3 cases were reported after dose 2 for a rate of 6.74 per million. In the vaccine safety data link population, there were 37,646 people who received at least 1 dose of JYNNEOS. There was 1 case of myocarditis observed after each dose. The VSD incident rate estimates have wide confidence intervals that range from about 1 to up to 250 cases per million. And these confidence intervals overlap published historical population background rates, which range from 2.7 up to 21.6 cases per million persons during a 30-day period. For context, the published historical rates after live replicating smallpox vaccines have ranged from 78 cases per million after Dryvax in a 2002 military cohort study, up to 5,000 per million cases after ACAM 2000 in a 2018 military cohort study. So in summary, the VAERS and vaccine safety data link data do not suggest an increased risk for myocarditis following JYNNEOS compared to these expected published background rates, but the possibility of a small risk cannot be excluded. Next slide. This slide shows a similar analysis for pericarditis. There were a total of 6 cases reported to VAERS, only 2 of which were classified as serious due to hospitalization. There were 4 cases after dose 1 and 2 cases after dose 2 for a rate up to 5.5 cases per million persons during a 30-day period. There were no cases identified in the vaccine safety data link population. The VAERS reporting rate for pericarditis is similar to expected published historical background rates and less than that observed after live replicating smallpox vaccines in 1 military cohort study. Next slide. I will now discuss overall findings from VSafe. Next. vSafe, again, is a smartphone-based system that uses text messaging to initiate web-based survey monitoring for adverse events following vaccination. vSafe is used to characterize the basic safety profile of a vaccine when given outside a clinical trial setting and can facilitate reporting to VAERS for medically attended adverse events. vSafe is meant to supplement CDC's other vaccine safety monitoring systems, VAERS and VSD. Next. vSafe for Mpox vaccines had 181 active participants, all of whom were adults and the majority male. Additional characteristics are shown on the slide. Next. This graph shows the percentage of participants who reported reactions or health impact events at least once during days 0 to 7 after vaccination by dose. About 80% reported any injection site reaction, and 5% sought medical care. No participants reported a serious adverse event. Next. This graph shows the types of injection site and systemic reactions reported by vSafe participants. The most common overall was redness at the injection site, reported by 64%, and the most common systemic reaction was fatigue, reported by 40%. Next. Next, I will discuss information about adverse events in persons less than 18 years of age. So CDC facilitated single-patient emergency IND authorizations from the FDA to make JYNNEOS available for persons aged less than 18 years when needed, prior to the JYNNEOS emergency use authorization being issued on August 9th, 2022 that allowed wider use in this age group. CDC solicited information from vaccine providers about adverse events occurring in their patients during the 28 days after each dose. Persons vaccinated under IND ranged in age from 4 months to 17 years, and 58% were male. Adverse events were reported for 18% of 57 people after dose 1, and in 21% of 24 people after dose 2. The types of events reported included injection site reactions of pain, erythema, swelling, and induration, and the systemic adverse events of fever, fatigue, and headache. No serious adverse events were collected in this project. Next slide. Sorry, next slide again. So VAERS was also used to collect data on persons aged less than 18 years. JYNNEOS was administered to 1,245 persons aged less than 18 years in the US during the surveillance period, and VAERS received 25 reports for this age group. Vaccinated persons' ages range from 12 to 17 years. Reports of vaccine administration errors accounted for 84% of these reports, with the most common being intradermal administration instead of subcutaneous, which again is the authorized route for this age group. The only adverse event reported was one person with syncope, and there were no serious adverse events reported. Next slide. So the overall conclusions about the vaccine safety monitoring are as follows. Next slide. So first, JYNNEOS post-licensure and post-authorization vaccine safety surveillance findings to date are consistent with those observed in clinical trials. No new or unexpected safety concerns have been identified. Serious adverse events were rare among adults, and none have been identified among persons aged less than 18 years. VAERS and vaccine safety data link taken together do not suggest an increased risk for myocarditis or pericarditis following JYNNEOS, but the possibility of a small risk of myocarditis cannot be excluded. This concludes my presentation. Thank you.
Thank you, Dr. Duffy. This presentation is now open for questions. Dr. Paling.
Thank you, Dr. Duffy, for this great presentation. I appreciate how you are using multiple systems, safety surveillance systems, to make sure that we fully understand the safety of JYNNEOS. My question is regarding vSafe. vSafe was, I believe, built by the CDC for the COVID vaccine to rapidly capture data, and I'm thrilled that it was used for Mpox as well. And can you tell us what were the modifications and how did that work? Thank you.
Yes, thanks for the question. So that's correct. vSafe was originally developed specifically for COVID-19 vaccines, and then they required both technical and sort of administrative modifications to make it available for a second type of vaccine. And so, you know, basically the system itself worked very similarly in the sense that people had to enroll themselves on the website, and then once they did that, they would receive the prompts to complete the surveys. And so, you know, I think the contrast with COVID was that the system was available and open for enrollment by the time vaccines were available, and then due to the nature of this emergency response, it took some time to make that website available for people to use for Mpox.
Thank you. Ms. McNally?
Thank you. Dr. Duffy, I'm the consumer representative, and I have just a couple of quick questions for you. Could you just explain for the benefit of the public what it means to have an absence of wheal without vaccine leakage?
Sure. So when doing an intradermal administration, the idea is that you'll get what's called a wheal or a small bleb where the skin is raised up after you're doing the injection. And so some people who have reported to VAERS have stated that when they've attempted to do the intradermal administration, they do the injection, but they don't see this wheal forming. And so that's why CDC issued some guidance to just indicate that just because you don't see the wheal doesn't mean that the intradermal vaccination was not successful.
Okay, that's helpful, thank you. And then on slide 68, it indicates, and recognizing the limitations of VAERS, the other vaccines on the same day, yes, and then it has 45. Is there any information about that?
Oh, sure. So people can receive other vaccines on the same day. So COVID-19 vaccines were the most common. There was 32 reports where people received both an Mpox vaccine and a COVID vaccine on the same day, but other people receive other vaccines such as flu vaccines and others.
So it was primarily COVID. Do we know what other vaccines?
Well, like I said, there's sort of a long list. I mean, flu was also common, but things like meningococcal vaccine, hepatitis A, et cetera.
Okay. And then my last question for you is there any follow-up that you're aware of that's happening where immunocompromised people are reporting side effects in VSafe?
Well, so if we go back to the VSafe slide, you can see that so sorry, it's
I have it as 79.
yeah, if you go down a few, but it's the second VSafe slide. But about 32 people, or 17% in the sample size, reported self-reported immunocompromised status. So that's a self-report.
But no follow-up that you know of?
Well, the follow-up isn't based on immunocompromised status per se. It's if people report medically attended events, they would have additional follow-up.
I understand. Thank you.
Thank you. Dr. Long?
I was wondering if Dr. Sanchez was responding to this, or is it something separate? Okay. My question is about myopericarditis, and it is reassuring that the rate clearly is lower than following Dryvax, which was a very severe myocarditis primarily. So that is good news. But the numbers are very small as far as number of people vaccinated to know more rare things such as myopericarditis. So I assume these were within a time frame following vaccination of something like 28, 30 days. And the second part is was that myocarditis of the traditional adult myocarditis and not the myopericarditis. That's a very brief episode of chest pain following coronavirus vaccine. And did any of them get coronavirus vaccine around the time they had their myopericarditis? Lots of questions, but did you tease out whether it might be in the window of vaccine associated, and did any of them get coronavirus vaccine?
Yeah, thanks. So if we could go to slide 90, this just shows the distribution of onset. So we included any cases that occurred with symptom onset within 30 days post-vaccination. And so these are the cases reported to VAERS. And so you can see that the myocarditis cases and the pericarditis cases had separate, sort of shown here separately. And then if we go to the next slide, just to address some of your other questions. So yeah, 4 of these cases were classified as myocarditis alone and 1 myocarditis with pericarditis. And so all of them were hospitalized, recovered, and discharged to home. So there were some other factors. One person had an Mpox infection diagnosed at the time of the myocarditis diagnosis. One of the people had a history of myocarditis about 10 years prior. 2 of these persons were HIV positive, but yeah, overall, there wasn't anything unusual about the presentation of these cases compared to other cases of myocarditis.
A quick follow-up question for my education. When you then looked at the 30-day window and you compared it with the background, do you then look at a background of myocarditis cases in 30-day period?
Well,
so what were the background denominator in time?
Yeah, that's correct. So, yeah, all the rates that were discussed here were adjusted for a 30-day period. And so, like the U.S. military study from 2002, which was one of the earliest ones published in sort of the modern era on this, originally looked at a 30-day period, and that's why we continue to use that as a sort of an a priori risk interval for consideration.
And for the population at large as well as the dry vax people?
That's correct. We adjusted all the rates for the same period.
Thank you. Dr. Daly?
Yeah, this is a follow-up question about use of vSafe. So, I think this is another example that reveals that we have this multifaceted safety surveillance system, and that each of these systems sort of complements the other in terms of strengths and limitations. They've got contrasting strengths and limitations. And I'm really glad that vSafe was used for this example, but then it had fairly low uptake, really. It's a couple hundred people. And so can you at least speak to, I realize this is a hard question, but sort of long-term use of vSafe with new vaccines, because we've got other vaccines coming down the pike, and is the intention that vSafe would be used in those circumstances? And I realize it's off topic of Mpox a little bit, but again, I find the data to date reassuring around it, around the surveillance, the safety surveillance data. But kind of how does vSafe fit into a long-term safety strategy, and what can we do to promote its use?
Okay, thanks. So yeah, as stated earlier, the role of vSafe is really to complement VAERS and VSD and provide a different type of information, which is more focused around those injection site and systemic adverse events, which would provide that real-world evidence similar to solicited adverse events collected in clinical trials. And so, yeah, so in this Mpox outbreak, I think part of the low participation was influenced by the timing of the availability of when the survey was rolled out. The survey didn't become available until November. As you saw, it was after many of the vaccine doses had been administered. But yeah, CDC plans to use vSafe in the future for other types of vaccines, and in a non-emergency response in a routine vaccination program. The expectation would be that that would be available at the launch or at the start, early in the vaccination program.
Thank you. Dr. Laird, did you have a question? No? Okay, we'll move on to Dr. Sanchez.
Thank you. No, and I agree with Matt's comment about the vSafe. As unfortunately, vSafe was not available when the rollout occurred initially. So there was a delay, and I think looking forward, as new vaccines are being FDA approved or under emergency use, it's the importance of starting that process quite early. But I do have a question on the vSafe. First of all, was the route of administration one of the questions, whether it was intradermal or subcutaneous? Because I think this also has a big impact on what kind of injection site reactions may have been seen, since with the intradermal there seems to be more local reactions that may preclude, that there's a lot of anxiety about that. And second of all, was any information captured on whether the individual, the woman, was pregnant? And is there any plans of having a pregnancy registry for also for the JYNNEOS vaccine as we move forward? Thank you.
Okay, so for your first question, so in vSafe, people were asked to report the site of vaccine administration, and about half the people who responded to the survey reported administration in the forearm, and about half reported administration in the upper arm, which is a slightly different question than route of administration per se. And so, and your second question regarding vaccination and pregnancy, so CDC is not aware of any persons who have received JYNNEOS during pregnancy in the course of this outbreak. There have been no reports to VAERS or anything about that situation. And the United States government does operate the National Smallpox Vaccines and Pregnancy Registry, which is operated by the Department of Defense. And that system is still in place, has been in place for 20 years, and has collected information on smallpox vaccines, and will now going forward also be collecting information on JYNNEOS.
So was there any difference then in adverse reactions among those reported in the forearm versus the upper arm?
I don't have a slide breaking that out, but due to the small sample size, it wasn't felt that would be a very fruitful comparison.
And so it's interesting. So we don't have any information then on the JYNNEOS vaccine in pregnancy. Is that correct?
Not to my knowledge.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives are going to follow up on Dr. Sanchez's question. So I think the clarification I would like to hear is when someone receives this vaccine and they use vSafe, is vSafe asking them if they are pregnant?
Yes, vSafe does have a question about that, but no one
Great.
said yes.
Yeah, and so with the COVID-19 vaccines, that pregnancy question stays with you for months and months and months after you've received the vaccine. So I'm assuming that the software is being used similarly with this vaccine. Like every time you get your little 1 month follow-up, your 2 month follow-up, it says, have you had this disease or have you been pregnant? So that's continuing, I'm hoping.
Yes, I mean, the vSafe for Mpox collection is scheduled to continue through March at this point, so we will be collecting additional data, but due to vaccine uptake, we may not have significant additional data in the future.
Thank you. I want to echo one more time just the general importance around vaccine safety monitoring in pregnant women and the incredible progress that has been made during COVID-19 vaccines. So I do hope that we can continue to leverage sort of the lessons learned from COVID-19 in a very positive way for both pregnant people as well as immunocompromised individuals, because I'm looking at my colleague, Dr. Cotton. The more information we can capture, and it's been incredibly effective. I have to say, I've never seen such a huge amount of data in pregnant people as I have following COVID-19 vaccine, and it was all very reassuring, which is extremely helpful during our communications. We'll move on to the next section. The next presenter is Dr. Kevin Delaney, who will speak about monkeypox vaccine acceptability and uptake from cross-sectional surveys.
Thank you. Can you hear me? Can someone in the room confirm?
We can. Please go ahead.
Okay. So today I'm speaking on behalf of the CDC Community Engagement Task Force from the response, and we'll be talking about measures of vaccine acceptability both among clinicians as well as vaccine interest, intent, and uptake among the general population and the populations disproportionately affected by the current outbreak. Next slide. One source of information for this is surveys of clinicians, and CDC has worked with CERMO to get some insights here. CERMO is an online community of more than 1.3 million clinicians. At the beginning of August, the company did what they call a barometer survey of physicians around the world, over 1,000 physicians total. And here I'm presenting data from the 415 US-based clinicians in that survey. The entire report is available at the link on the bottom of the slide and has a lot more data, but I just want to highlight that in early August, the majority of clinicians surveyed wanted more access to vaccine. And then on September 12th, they conducted a short follow-up survey at our request and found both high vaccine demand and acceptability, with 76% saying they knew where to send patients for JYNNEOS vaccine. And more importantly, I think 86% wanted to be able to offer vaccine in their practice. Next slide. Now I'll just transition to present data from people who would be receiving the vaccine. Next slide. So this slide is just meant to provide an outline and overview as I move through 4 surveys conducted by CDC and partners during the current outbreak. Next slide. The first survey I'll talk about is one that CDC conducted in partnership with Porter Novelli. Next slide. Porter Novelli is a contractor who conducted 4 online general population surveys of US adults through the months of August, September, October, and then in December on knowledge, attitudes, and beliefs of Mpox-related topics. The data are weighted to match US Census proportions for age, gender, region, race, ethnicity, and education. And they also ask a question about whether or not the respondent considered themselves a member of the LGBTQ plus community. In the December survey, we had the largest sample and asked several questions specifically designed to directly measure Mpox vaccine value and in this general population survey. Next slide. So here you can see that overall, very few people disagreed with the statement that Mpox vaccine was safe, although many of the general population, even those identifying as part of the LGBTQ plus community, said they didn't know. But for the current outbreak, which overwhelmingly has affected gay and bisexual men, as Sasha presented earlier, 51% of those who identified as LGBTQ plus thought the vaccine was safe. And 50% of that group also thought it was important to get the Mpox vaccine to protect themselves. For this second question, it's also interesting that 31% of those who did not identify as LGBTQ plus or a member of the LGBTQ plus community also felt it would be important to get the Mpox vaccine to protect themselves. Next slide. So now I'll move to surveys and data collected from the community most affected by the current outbreak, gay and bisexual, and other men who have sex with men. First, I'll describe results from sexual minority men screened for enrollment in the Amethyst cohort. Next slide. The American Transformative HIV Study, or Amethyst, is an NIH-funded online cohort that will eventually include 5,000 sexual minority men. It's a diverse group with higher risk of HIV acquisition than the general population, even of sexual minority men, by design. They will be recruiting so that the cohort is no more than 50% non-Hispanic white, so majority minority by race and ethnicity, and then 60% of the cohort will have reported recent methamphetamine use. To get to the objective of enrolling 5,000 such men, they plan to screen over 30,000 respondents with an online eligibility survey. And they added questions about Mpox knowledge, vaccine uptake, and behavior change to their screening enrollment survey. The data I have to present today are from the first 8,500 participants screened from August 6th through November 15th, 2022. Next slide. This is a graph of responses to the question, how much have you worried about Mpox infection over the last 2 weeks? The bars represent month of recruitment, and within a given bar, blue represents worry some or more than half of the days in the last 2 weeks, while the orange represents those who said they never worried about Mpox in the last 2 weeks. And you can see that blue gets smaller and orange gets bigger as the outbreak slowed through the fall, meaning the proportion of people worrying about Mpox in the past 2 weeks decreased. But nonetheless, in November, approximately 1/3 of participants remain concerned about Mpox. Next slide. This graph on the right is similar to one that CDC has for COVID vaccine confidence. Again, each bar is a month of recruitment, this time with November on top and August on the bottom. Here, blue is vaccinated, orange and gray are those who have an intention of getting vaccinated for Mpox, and yellow is the group who said it was unlikely they would be vaccinated for Mpox. You can see vaccine coverage doubled from August to September, but then flattens out. And I think this is consistent with the vaccine administration data that Sasha also presented earlier, with 30% of those recruited in November reporting having received at least one dose. However, the proportion of people reporting intent to take vaccine remained strong, and there was minimal increase in the proportion of people who said they were unlikely to get vaccinated. So overall, 85% of those enrolled in the survey so far are either vaccinated or reported being likely to get vaccinated. Next slide. However, here's a graph of vaccine uptake by race. Again, for the months go from August on the bottom to November at the top. Next slide. If you look at August, you can see that among the Amethyst participants surveyed way back at the peak of the outbreak, Black men actually had the highest proportion reporting receipt of at least one dose of vaccine. Next slide. However, if you concentrate on the bars for Black men month over month, you can see that the doubling in vaccine uptake that we saw overall did not look as impressive for Black men. And really from September on, Black men reported lower uptake of vaccine than any other races. Next slide. And this manifests when we look at the overall coverage from the entire survey combined. So for August through November altogether, we see significantly lower vaccine coverage for Black men. It's also important to think about other communities in terms of equity, and Amethyst may be our only or best source for this, but we see much more lower uptake of vaccine for gender diverse persons and for those who do not identify as gay. So as we move forward with plans to improve equity and access, I think we need to do a better job specifically marketing and creating demand for those groups as well as Black men. Next slide. So next I'll talk about another online survey of gay and bisexual men. Actually, 2 of them conducted by colleagues at Emory University through their American Men's Internet Survey. Next slide. The American Men's Internet Survey is more commonly referred to as AMOS, and it's an annual online cross-sectional survey of people who were born and currently identify as male, typically conducted with recruitment October to February of a given year. In August 2022, Emory conducted a special one-time survey, recontacting men who participated in the 2021 AMOS survey cycle, so interviewed between October 2021 and February of 2022, to explore knowledge, attitudes, and practices related to the US Mpox outbreak. The survey was conducted between August 5th and 15th during the peak of the current outbreak. For those that are interested, Emory posted all of the questions that were asked in the August survey online. And there are questions in this survey about vaccine knowledge, access and desire to be vaccinated, barriers to vaccination, and sources of information on Mpox. As published in an MMWR that first appeared online August 26th, 53% of AMOS participants reported concern about getting Mpox at that time. And at that time, 18.6% of MSM surveyed reported having received at least 1 dose of vaccine, which is very consistent if you think back to the August part of my data from Amethyst. Next slide. But in that MMWR, we also reported vaccine uptake for Black men compared to all other racial groups, lower vaccine uptake in more rural areas relative to urban areas, and lower vaccine uptake in the South and Midwest. So this, again, was published August 26th. We called for more equitable vaccine delivery. The bold here is quotes from the discussion section, emphasizing engaging diverse partners who are already working with special populations, delivering vaccine through mobile outreach and pop-up events, and diversifying times and locations and expanding geography. So making the recommendation so that anyone who needed or wanted vaccine, needed vaccine, had access to it. Next slide. And 4 days after publication of the MMWR, the White House announced plans to support expansion of vaccine access through distribution to groups working to provide vaccine at large events and in spaces where they could reach populations that otherwise might not have access. I think this is getting at one of the questions that was asked of Dr. Ellington after her presentation. Next slide. So that program provided an additional vaccine above the original allocation to 15 jurisdictions, 14 states and Puerto Rico, for 28 different vaccination programs and events. And these were, again, beyond their threshold supplies provided by states, provided to states. And this project delivered nearly 25,000 doses of vaccine at these special vaccine equity events. Next slide. So now I'll talk about what we know from the 2022 AMOS cycle, which is currently still in the field. Next slide. Again, this is for 2022-2023 AMOS, which is we're still recruiting. These data are from an abstract developed for submission to the International AIDS Society meeting, but are not yet published. Recruitment began in early October, and by the end of December, over 3,000 men had been enrolled. And at that point, 33% reported they had received 1 dose of vaccine. Again, very consistent with the Amethyst data for November and December. Vaccine uptake was associated with Mpox awareness and concern, and also with factors that might be indicative of concern for or awareness of sexual health and access to sexual health services overall, including HIV care, STI testing, and HIV PrEP use. Next slide. Finally, I'll talk briefly about a study that was done by CDC and the San Francisco Health Department, specifically recruiting another special population, people experiencing homelessness in San Francisco. Next slide. This study was fielded from October 23rd through November 5th and sought to understand Mpox vaccine coverage and acceptability among people experiencing homelessness. This study also collected blood to assess seroprevalence in this community, but I won't be talking about that today. Next slide. This is another graph of vaccine acceptability. The coloring's a little different than the amethyst data, but here blue represents the combined proportion of those who had already been vaccinated or said they would accept vaccine. And the smaller yellow group is the proportion who said they were unsure if they would accept vaccine, and gray would be the proportion who had already declined an offer of vaccination or would decline. So those who didn't want the Mpox vaccine. The top bar includes all participants who reported any higher risk sexual activity. The bottom bar includes only gay, bisexual, and men who have sex with men. And the callouts give the take home here that 56% of those who reported any sexual risk and 74% of MSM, again, pretty consistent with the amethyst data, said that they would accept Mpox vaccination. Next slide. So I just want to close by acknowledging both all the members of the CDC Mpox Outbreak Response Community Engagement Task Force, as well as all the external partners who we contacted and worked with to collect and disseminate these data so quickly. So thank you.
Thank you very much for that presentation. This presentation is now open for questions. Dr. Paling.
So I want to say thank you for presenting diverse studies, and it's amazing how many different partners were done to engage in communities at very high risk. And so I want to congratulate you and the team in pulling all this information together. It's very timely and important. I very much appreciated the comments about engaging diverse partners already in the community. That is a common thing we hear in our community as well. And I loved the vaccine equity pilot program. I was wondering, do you have any data about who was enrolled in the 25,000 doses that were administered? Do you have the demographics and some characteristics of the people who received that? Thank you.
Yes, I don't have the actual slide, but off the top of my head, of the 25,000, they combined, they were majority minority, and they were predominantly gay and bisexual men. We don't have a lot of data from the vaccine equity pilot. It's basically data that is available in the vaccine registry. For the jurisdictions that received extra doses. So we don't have detailed behavioral data or potential exposure, but they did reach populations that otherwise didn't have access to vaccine. There was a question fielded in San Francisco, Oakland, and to a small number of other jurisdictions about reasons for accessing vaccine at the equity pilot. And the most common reasons for not accessing vaccine before that were lack of information about where to get vaccine. It was not lack of desire to get vaccine before being presented with it at the vaccine equity pilot. It was just not being able to find a time or a place to get vaccine. And everyone who we did interview as part of the follow-up there, small sample of all that received the vaccine, but they all were very appreciative of having essentially the vaccine brought to where they were as an intervention.
Thank you so much. Ms. Bata?
Thank you, Dr. Delaney. Just a little more information about the survey that was conducted among clinicians. What kind of practices did they represent? I know that with this shortage, within our own state, we actually had very specific clinics that we provided vaccine to that we knew would reach communities of focus, or our BIPOC communities and our disadvantaged communities. And so we know that providers didn't get the vaccine, but I would be interested to know what their practice was and how they represented our broader diverse population.
So they were mostly primary care or infectious disease. I think they, in terms of geography and racial distribution, I think they were mostly in the Northeast. the survey was quick and was only open for 48 hours or less. The follow-up survey in September. The earlier survey, the data are available online, and there's a more diverse pool of respondents from the U.S., and I would refer you to that report for more information.
Okay. Oops. I'm going to go online and ask Dr. Brooks if he would like to ask a question.
Yes, thank you. Excellent presentation, Dr. Delaney. And just noting that we're looking at safety data, efficacy data, and outreach. So I think it's just showing a good approach in general to how we view a theoretical upcoming vote on this vaccine. My question is, you showed a slide where African Americans at the beginning, I believe it was August, had the highest rate of uptake of vaccine, but as time progressed, became the lowest rate. And it may not be you to answer this question, but was that more related to uptake, access, or do we feel it was more related to just lessening interest in the vaccine?
So I think that some of the Amethyst questions could unpack that a little bit, but we haven't sort of looked at intention to get vaccine by race and ethnicity yet. But so I can't completely answer your question, but I can say we can look further into that with the Amethyst data.
Thank you.
Thank you, Dr. Sanchez.
Thank you. I've been impressed by, not so much vaccine availability, but really how this targeted population that just doesn't know much about the vaccine and possibly even about the disease. And I think that the public health has to be has to also not just provide sufficient doses for these populations, but I think there's a big education campaign that needs to be done, because one of the don't know among even part of the LGBTQ community was 32%, which is substantial. So I think that the focus also needs to be on education and making high-risk groups aware of the problem. Thank you.
And I will say that the Porter Novelli survey that the 32% comes from included not only gay and bisexual men, but other LGBTQ plus people. It was so it was at least half LGBTQ plus females who weren't really part of our communication campaign because they weren't really part of the sort of largest numbers of the outbreak. I think that our work with the Amethyst and Amos cohorts did show that there were gaps in knowledge, even for MSM, but we adapted based on those early survey results, our messaging to be more sex positive and to ensure that the vaccine was being talked about as a sexual health intervention, because most of the places where the vaccine was available outside of the health equity events were STI clinics and PrEP clinics and HIV care sites. So we did adapt the messaging, and I think the work of the community engagement task force folks who developed the materials and the social media marketing and worked with our community partners to get the message out to the most affected communities. I want to say that I'm really proud of the work that group did during this outbreak, because I feel like we took a very community-centered approach to getting the word out. But I agree with you that we need to do more.
Thank you. Dr. Long?
Yes, it's a little bit more of a generic question. All work groups struggle with equity. And would a recommendation increase or decrease or not have an impact on equity? And here's an example where the disease itself is more likely to occur. I don't like to call it race because these are mainly socioeconomic, disadvantaged, and cultural questions, not what is your race. But here's one that does affect the disadvantaged more than anyone, and you would think that a vaccine that protected individuals would increase equity, and yet there's an example of the use already that it in fact decreased equity. And so can you tell us, maybe Dr. Wharton and Dr. Lee, how, should we continue to judge in our work groups the equity issues on a perfect world when the groups we're most interested in increasing their equity will have uptake? Or do we factor in that it's less likely that these very groups will be immunized, and in fact, the policy would decrease equity?
Clearly, we want implementation strategies that address these fundamental inequities, and I think we would not introduce a vaccine because of differential uptake in different populations, but we clearly need implementation strategies that address the need to reach all populations.
And I'll just, actually, I'm so glad you asked that question. I don't know if I have a particular answer, but I was actually going to comment on a couple of aspects of equity. One is, so our role as ACIP members is to really think about what recommendations we make. And I think it's our job to consider implementation as one of the domains in our ETR framework as relevant to how equity is achieved. Although we are not the implementers in this case, and we rely very much on our partners with the front line to be able to deliver vaccines and provide our recommendations, I do think we have an opportunity to, and clearly a platform for us to be able to at least highlight the issues where inequities exist. Because I think if we can consistently do that in all of our domains, as we discussed with COVID-19 vaccines, it gives us the opportunity to share the kinds of information that our talented CDC colleagues have shared with us already about the epidemiology, about the sort of the disproportionate burden in certain populations. And I'll just highlight one specific aspect that keeps coming up with COVID-19, and it was mentioned today with monkeypox vaccines. And I was actually just struggling with how to think through this. So when we think of high risk, we think of high risk typically in the context of they are more likely to have severe disease or complications associated with an infection. But I think we also have considered with an available vaccine that would be effective, what is high risk of exposure and what does that mean? And I highlight this partly because the rural-urban distinction keeps coming up. And to the points made earlier, it's not, sometimes there are assumptions made that it's an acceptability issue when in fact it may be an access issue. And so thinking about how to articulate that, highlight that as an area of opportunity for us, and how to think about strengthening our public health infrastructure and community partnerships, I think is relevant to our conversation, even though we are not directly delivering it. This, I'm going to say this is my personal opinion. I'm not representing ACIP, but as an ACIP member and having gone through this journey with all of you over the past 3-6 years, I do think it's been clear to me that we do have a responsibility and a voice to be able to share with the public and with our colleagues. Thank you. Dr. Paling.
So I am so appreciative of this conversation, and I wanted to highlight an opportunity because we do have an issue with equity, and we're all striving to do that. And one approach to doing that is positive deviance, finding the few cases where they're doing it well and learning from them to spread. And so I would encourage us to think about ways to highlight true successes and figure out and learn from them. Thank you.
Thank you. Dr. Lehr?
I also want to say thank you for your comments, because I was struck by the number of people who are interested in the vaccine, talking 80–85%, and the number of people who actually have the vaccine. And that disconnect suggests that there's creative work to be done.
Thank you. Dr. Zahn?
Yeah, thank you, Dr. Lee. And thank you, Dr. Long, for raising the question, and thank you, Dr. Lee, for talking through the issue. I would just say from a local public health standpoint, an awful lot of achieving equity, of the aspect of achieving equity, is a matter of having adequate resources for both local public health and their partners to conduct effective outreach to those who are at higher risk. At the same time, we certainly appreciate ACIP's guidance and identification of potential equity issues so that those issues can be raised and funding can be and resources can be directed accordingly. So very much appreciate the comments from all involved and concerns about equity.
Thank you. And Dr. Long, you'll get the last word.
A very short comment. Thanks for reminding me, Dr. Paling, about things that work well. In pediatric vaccines, equity has always been increased, and that's because we have vaccines for children. And we need to have the same kind of thing because in the adult world, as I'm learning being on work groups that affect adults, that it just increases inequity when we have these barriers. Thanks.
Okay, thank you. And Dr. Talbot, last comment.
I was just going to say amen.
Thank you, Dr. Talbot. Next, we'll move on to Dr. Rosalind Carter, who will speak to monkeypox vaccine implementation and interim clinical considerations.
Good morning. Next slide, please. Today, I'll be presenting a brief overview of the CDC interim clinical considerations, which were developed to guide vaccine implementation during the current Mpox outbreak. It's important to remember that the ICC is a living document. As the epidemiology of the outbreak evolved and as we received feedback from the field in terms of new questions and concerns, the guidance was updated or clarified. In the latest ICC updates, we continue to emphasize the importance of vaccination before exposure for those with the highest potential for exposure to Mpox, the importance of identifying and vaccinating persons living with HIV or who have other causes of immunosuppression, who've had recent or anticipate potential Mpox exposure, and finally, including explicit language stating that the definitions of risk groups also include adolescents. Next slide. From the beginning of the 2022 Mpox outbreak, the US government recognized that Mpox vaccine availability was the critical strategy to limit the rapid spread of Mpox. 2 vaccines may be used for prevention of Mpox and were available from the Strategic National Stockpile. They included the JYNNEOS vaccine, approved for prevention of smallpox and Mpox and licensed for use among persons 18 and older. And on August 9th, FDA issued an expanded use authorization, or EUA, for intradermal administration among persons 18 and older. And it's the primary vaccine being used during this outbreak in the US. ACAM 2000 is an alternative to JYNNEOS, approved to protect against both smallpox and monkeypox, but was not used during this outbreak due to the higher risk of severe adverse events. Next slide. On June 28, 2022, the federal government announced an enhanced nationwide strategy to vaccinate and protect people at risk for Mpox, prioritize vaccines for areas with the highest number of cases, and provide guidance to state, tribal, local, and territorial health officials to aid planning and response efforts. Multiple federal agencies, including ASPR, Strategic National Stockpile, BARDA, CDC, and FDA, are working closely with partners to ensure there are enough vaccine doses available to vaccinate all people for whom vaccine is recommended. Next slide. There are 2 primary strategies. First, the vaccination of individuals after known or presumed exposure to someone with Mpox. And second, vaccination prior to exposure among persons at high risk for potential exposure. Next slide. The next 2 slides provide additional details for how CDC has defined people eligible for vaccine in the interim clinical guidance. First is vaccination after known or presumed exposure to Mpox virus, including people identified as a contact to someone diagnosed with Mpox through contact tracing, people aware that a recent sex partner was diagnosed with Mpox, or gay, bisexual, other men who have sex with men, and transgender or non-binary people, including adolescents who've had sex with multiple partners at a commercial sex venue, or sex in an association with an event, venue, or defined geographic area where Mpox transmission is occurring. Next slide. This slide defines groups eligible for vaccination prior to Mpox exposure who either have highest potential risk for exposure or who anticipate potential exposure to Mpox. This includes people who've had a new diagnosis of an STI, such as chlamydia, gonorrhea, or syphilis, or who have more than one sex partner, sex at a commercial sex venue or in association with a large public event, people with HIV infection or other causes of immunosuppression who've had recent or anticipate potential Mpox exposure. And this also includes people at risk for occupational exposure to orthopox viruses, including research laboratory or clinical laboratory personnel. And this is all in accordance with the ACIP 2022 recommendations. What I want to point out here is that although the language describes the highest risk groups, in an effort to improve equitable access to Mpox vaccines, persons who request vaccination can receive it without having to attest to meeting any of these specific criteria above. Next slide. Health equity principles outlined in the interim clinical guidance are incorporated into the national vaccine strategy as well as local implementation efforts. Some of these principles include engaging people from affected communities in the planning and design of vaccination efforts, engaging diverse partners already working with special populations. We see many examples where health departments worked with their HIV program experts and community-based organizations to assist with Mpox vaccine implementation. Bringing vaccines to where affected populations live and work through pop-up events and mobile outreach conveniently located in communities and neighborhoods. Offering multiple appointment times and flexible walk-in opportunities, including evenings and weekends, to improve vaccine accessibility. And leveraging clinical venues such as the federally qualified health centers that serve people who have historically had less access to primary care, and also using sexual health clinics, transgender health clinics, and pharmacies to deliver vaccines. Next slide. So just looking quickly at the data, this slide shows the total number of vaccine doses administered and reported to CDC through February 7th on the x-axis. Almost 1.2 million doses were administered through current date, including 734,000 first doses and 452 second doses. The red arrow here indicates the week, August 7th through the 13th, where the EUA for intradermal administration was introduced. Now, at the same time, additional vaccine vials were released from the Strategic National Stockpile and provided to the states. However, intradermal dosing greatly expanded the number of people vaccinated with first and second doses during the peak of the outbreak when demand was highest, as shown on this slide. Next slide. So during Dr. Ellington's presentation, we looked at data comparing Mpox cases to those vaccinated by race and ethnicity. And here we're looking at whether vaccine equity improved over time. Note completeness for race and ethnicity data in our vaccine administration database was very good quality. Over 91% of this information was completed. Each bar in this slide shows the proportion of persons in 8 different racial ethnic groups receiving a first dose of vaccine. The bar on the left summarizes the overall data from May through the end of January, and each subsequent bar to the right shows first doses by month on the x-axis, and the percent of first doses represented by the different racial and ethnic groups on the y-axis. Comparing the time periods mid-June to mid-July and then mid-July to mid-August, which is the signified by the red arrow, we note that the proportion vaccinated who are Hispanic increased from 19 to 23%, and the proportion of people vaccinated who were Black non-Hispanic increased from 7 to 13%. These proportions were maintained over time, but improvements in vaccine equity in subsequent months have been modest. Please note that this data summarizes the national picture, and individual jurisdictions, including many of the highest burden states, have made substantial progress in addressing equity gaps. Nonetheless, we have much work ahead in implementation to improve vaccine equity. Next slide. I wanted to highlight a few elements of the current vaccine implementation as best practices for future outbreaks. Vaccine strategies and implementation were adapted to local situations, local epidemiology, and population needs. This included adapting the eligibility criteria for local context. Some examples of this are some states included sex workers in their definition of vaccine eligibility. Many others removed sexual orientation labels from eligibility criteria and reduced potential stigma by allowing participants to self-attest to eligibility. The interim guidance for eligibility also evolved as the epidemiology changed over time. It was very dynamic. We recognize that vaccination offered in the context of broader prevention activities, as well as sexual health care, including HIV testing and PrEP initiation, both increased access to vaccines as well as acceptance of vaccines. We cannot emphasize enough the key role that community-based organizations had, both as trusted messengers and as logisticians in helping set up vaccine events in their neighborhoods and communities to the success of vaccine implementation. And finally, we also want to highlight the importance of planning resources for data collection, including collecting vaccine status and dates of vaccination on monkeypox reporting forms, which allowed us to measure vaccine performance early on in the rollout as presented by Dr. Chard. And finally, the essential role of equity data to drive program actions and course correction as we've discussed this morning. Next slide. In closing, I wanted to summarize a few of the success stories of vaccine implementation. There were many challenges, most notably the limited supply at the peak of the outbreak in mid-July, when demand was highest. The intradermal route of administration was an important public health intervention, increasing our vaccine supply 300 to 500% when it was most needed. Our ASPR colleagues handled the complex logistics of moving JYNNEOS vaccine from the federal strategic national stockpile to the jurisdictions. However, at the beginning, SNS was limited to only 5 shipments per week during the outbreak peak, leaving the jurisdictions to manage redistribution to providers in critical areas. However, within about 6 weeks, ASPR was able to increase their shipping capacity to provide directly to providers. The change from subcutaneous to intradermal administration required jurisdictions to provide skills training to vaccinators. However, on average, those jurisdictions were able to begin implementation of intradermal within 2 to 3 weeks of the EUA, which was a really significant accomplishment and heavy lift. Initially, health departments and public clinics were the primary vaccine providers, providing more than 50% of all vaccinations. But as the outbreak has subsided, the jurisdictions have increasingly engaged STI and HIV care providers, as well as in some states, pharmacies to take on these roles. And finally, in closing, again, I just want to acknowledge the dedication and the hard work of the jurisdictional health departments who are truly responsible for the successful implementation of Mpox vaccines. Thank you, and I'm happy to take any questions.
Thank you. This presentation is now open for questions. Dr. Lair.
Thank you for your lovely presentation. My only experience with intradermal treatments are with a PPD when people are getting that every year. Is this vaccination just similar to that?
Yes, it is the very similar technique. So in some jurisdictions that, and with vaccinators who are familiar with those techniques, this was not too difficult to implement. I think for other vaccinators, there was a learning curve, supervision that took place, training that took place. We put together videos, and I think we also made changes in response to feedback we received from the field regarding how people felt about getting the intradermal vaccination on their forearm, and were able to also provide training on delivery of intradermal dosing on the deltoid area as well as subscapular area, which also improved, I think, acceptance of intradermal.
Thank you.
Thank you, Dr. Paling.
All right.
This is more of a comment than anything. Oh, sorry. I think that the launch of this was really difficult because the system, the vaccine distribution system, was totally different than what all of the public health immunization programs had been utilizing beforehand. And not only that, in discussion of the issue of equity, the states were only allowed 5 sites to receive vaccine, and that was one of the reasons why there was such limited distribution of the vaccine. And so I think that if we are going to use the national stockpile via ASPR, we need to think about the efficiency of that distribution system.
Thank you, Ms. Mata. Dr. Paling?
All right. So, Dr. Carter, thank you for this presentation. And building on what Lynn Bata just said, you really highlighted the complexity and how many people were involved, both on the front line and behind the scenes, to make this happen. We really appreciate that. I also very much appreciated your slide showing the vaccine first doses by months. It very much addressed the equity issue and demonstrated clearly that the concerted efforts were effective. I would encourage all the jurisdictions to look at their data in a similar way, because I do think that some people did this really well, and if they could share that, it would enhance everybody's efforts. And then I just wanted to highlight your comment about immunization registry reporting, because that is a critical component of how children's vaccines has been successful. And we just created bidirectional communication for children and adults in our hospital system. And on the very first week, someone showed up in the travel clinic for Mpox vaccine and forgot they had received their second dose in the health department several counties away. And so we were able to avoid submitting an error because we could see it. And so I think it's essential for Mpox, but it's essential for the entire adult immunization registry. Thank you.
Thank you, Dr. Paling. We'll move on to Dr. Bell.
Thank you so much, and thanks for this presentation. I just wanted to add to some of the comments of my colleagues, the last 2 colleagues or so, and use this as an opportunity to make a bit of a comment here. I think this presentation is particularly useful in terms of summarizing best practices and what worked in the context of this outbreak. And since we're considering approving the use of this vaccine in future outbreaks, I really hope that we can use these lessons learned and prepare ahead of time, not only for Mpox outbreaks, but other outbreaks. That's sort of the whole point here. And I find personally sometimes discouraging as the attention and the pressure around an outbreak starts to wane, the resources go away, people are pulled in other directions, and then we find ourselves not having made the best use of all that we learned in the previous outbreak. And so in this situation, for example, I think that the messages around the engagement of the local communities and the ability of the local health departments and their partners to know their communities and be able to mobilize quickly is just really key. And in that context, I certainly hope that those who hold the purse strings remember that here we have very clear examples of the sorts of things that we need to be able to do. And hopefully we won't have to spend months gearing up again as we had to do in the context of this very kind of new and unexpected outbreak. Thanks.
Thank you, Dr. Bell. We'll move on to Dr. Idris.
Thank you. This is Marcy, excuse me, Marcy Dries from Shea. I apologize for missing the roll call earlier. I have two kind of unrelated comments or questions. So the first one is around occupational exposures. And I appreciate the guidance focusing on laboratorians because I do think they are at higher risk. But is there any comment about frontline healthcare workers who may be caring for patients with Mpox or patients at high risk for Mpox? Just because I don't think that vaccination should be recommended for that group, but like my state, for example, has offered kind of a, I guess we'd call a permissive recommendation that healthcare workers may be vaccinated if they want to. And, you know, I think we should have some consistency around whether that's actually a recommendation or not. You know, there have been cases reported in healthcare workers, some related to sharps exposures when unroofing Mpox lesions, but some not. But I think, you know, the best solution there is to focus on not using sharps and using proper PPE, which I think was not used in all the reported cases. So, you know, I think it would be nice to have an overall statement saying that ACIP does not recommend routine healthcare worker vaccination for frontline care workers. But I also would like a little bit more guidance about, you know, when would you offer post-exposure prophylaxis to a frontline healthcare worker who maybe wasn't using PPE and later found the patient had monkeypox? You know, in what scenarios would you or would you not offer JYNNEOS as post-exposure prophylaxis? And maybe that's in there and I haven't seen it, but that's the end of my first question. So I'll pause here.
Thank you so much, Marcy, for that question. To the first part of that question, recommendation for healthcare workers working with potential patients with suspect Mpox. We worked closely with our healthcare worker safety task force and our NIOSH colleagues who looked at this very carefully. And the conclusion was that PPE recommendations were provided adequate protection against risk of Mpox transmission, and therefore we did not recommend JYNNEOS vaccine for healthcare workers. I think the permissive attitude you may be referring to is we did have questions with the intradermal dosing. If there were doses left in a vial that were otherwise going to be wasted, could they be used for healthcare workers? That was left up to the jurisdictions to make those decisions. But our overall stance was that healthcare workers could protect themselves with PPE and were not eligible for vaccine. That this was limited to the ACIP recommendations for 2022 for occupational exposures.
Yeah, no, I absolutely agree with that. I'm just saying, I think when it got down to the local jurisdiction level, that was not quite the interpretation. It was left more open to healthcare workers. I don't think the demand was very high, so I don't think that was an issue. But once there were more supplies available, it seemed like, at least in my state, it was more available, not just with leftover doses. So
sure, and I'll turn to Agam to respond to that question around post-exposure use of the vaccine for post-exposure prophylaxis for needle stick injuries, et cetera.
Yeah, thanks. This is Agam Rao. So I'll just say that it's true that the number of infections that we've heard of in people who are healthcare personnel that were exposed at work is very low. I think the last I heard, and it could be a little bit higher than this, but the last I heard it was like 10 or less. So it was few, and they were predominantly sharps injuries. So people who were attempting to aspirate lesions or unroof lesions to get samples. We did come out on the CDC website and also on COCA calls explicitly saying that we do not recommend that be done, that unroofing the lesions are not necessary, that very good specimens are being obtained just from vigorous swabbing of the lesions, and so there really is not a need to unroof lesions. And perhaps that's cut down on the risk for sharps injuries. There have been a few cases, very few, that that are unexplained and that the individuals don't have any personal risk factors that we're aware of, and also cannot recall caring for a patient with Mpox and seem to have developed Mpox. The good news is that those individuals had self-limited illness and recovered very quickly. But we do offer, post-exposure prophylaxis is something that should be considered whenever there is an exposure that is high risk or the individual is someone who is at high risk. So if there was a needle stick injury, if there was contact with lesion material when without gloves, for example, any of those times that the infection control personnel or the clinician themselves feel that they were not adequately protected, then they should be offered post-exposure prophylaxis. And if the individuals go on to develop illness, we do have therapeutics available that can be considered depending on the severity of the illness or the severity of the underlying conditions that the individual exposed had. So we don't actually define which types of exposures would require post-exposure prophylaxis. But it's something for us to think about based on your suggestion, Dr. Dries.
Thank you. And
yeah.
We are almost out of time. So Dr. Dries, did you have one last comment or question?
Yeah, my only other comment was around, just as wearing my other hat as an HIV provider, is if we continue to have the flexibility to offer either the intradermal or subcutaneous route of administration, I think that's really helpful. At this point in the outbreak, we have 1s and 2s that might still need to be vaccinated. We don't have the demand for the vaccine clinics anymore. So being able to offer just, 1 dose without wasting the rest of the vial is really helpful. And I think it was alluded to, but some patients have found the intradermal administration on the forearm to be quite stigmatizing. So we do have options, obviously, to put it elsewhere, but subcutaneous might be preferred by some patients as well. Thank you.
Thank you. Ms. Howell?
Yes, Molly Howell, representing the Association of Immunization Managers. I just had a couple of comments. One, I wanted to echo Lynn Bada's comments regarding the use of traditional systems in response to emergencies for vaccine ordering and management. These include immunization information systems and CDC's vaccine ordering system, VTRAX. It was very time intensive and difficult for states to implement a new system during the monkeypox response. And so it would have been appreciated to use the systems that we used successfully during the H1N1 response and COVID vaccine response. And if new systems are going to be used in the future, we would appreciate any information on those systems now so we can plan for their use and electronically connect our immunization information systems to those systems. The next comment, or I guess kind of a question, I was just wondering if the clinical considerations will include an allowance or guidance for using a delayed second dose strategy during an outbreak situation, similar to what New York City and Quebec used in response to the monkeypox outbreaks. Thank you.
This is Agam Rao. We can talk more about that perhaps after the next presentation. So we'll be talking about the evidence to recommendations framework and I suppose soliciting input on what sort of information should be included in the clinical guidance of the MMWR.
Thank you. And Dr. Rao, why don't we please go ahead with your presentation? Dr. Rao will be presenting on the evidence to recommendations framework, vaccination with JYNNEOS during monkeypox outbreaks.
Great, thank you. So I guess we're going to switch gears just a bit. We were focused up until now on presentations specific to the ongoing outbreak that's going on, the Mpox outbreak. And I'll now present the evidence to recommendations framework, or ETR, for vaccination with JYNNEOS during any Mpox outbreak. So not limited to Mpox that is being currently transmitted, but Mpox that could be spread through, for example, travelers from countries where it is endemic, or prairie dogs again, or any other animals, imported animals. I do want to just ensure that everyone's aware that we do not think that this outbreak is over, and so that's very important to keep in mind, even though we are proposing this vote for Mpox during, or JYNNEOS for Mpox outbreaks. That does not mean that this outbreak is over. It is still going on. We encourage people to continue to be vaccinated. And also we rely on the interim clinical considerations that Dr. Carter summarized in her slides for specific populations for whom JYNNEOS is recommended during the current outbreak. So I'll now present the ETR. As a warning, there are photographs in this presentation that might be difficult for some viewers, and I will give you a heads up before I show those 2 slides, but there are 2 slides. So the Evidence to Recommendations Framework, or ETR, is a structure to describe information considered in moving from evidence to ACIP vaccine recommendations. It provides transparency around the impact of additional factors on deliberations when considering a recommendation. There are 7 ETR domains: public health problem, benefits and harms, values, acceptability, equity, feasibility, and resource use. I will present the work group's interpretation of the data for each of these domains and the response to the questions on the right side of this table. The ETR question is, does ACIP recommend the 2-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of Mpox during an Mpox outbreak? So 2-dose series because there's a first dose and then the second dose is administered 1 month after dose 1. And it's important to keep in mind that when we refer to an Mpox outbreak, we're referring to an increase in the number of cases from baseline. So public health authorities will determine whether there is an Mpox outbreak. A single case could be enough to be considered an Mpox outbreak at the discretion of public health authorities. And there are other circumstances in which a public health response may be indicated, including an ongoing risk of introduction of Mpox into a community due to disease activity in another geographic area. So it's somewhat flexible what an Mpox outbreak is. I'll start off by discussing the first domain, which is the public health problem. So as Dr. Sanchez already mentioned, there have been several notable public health events involving Mpox since it was first recognized in humans in 1970. Early cases were in rural settings in certain forested regions of Africa where the presumed animal reservoirs reside. The first outbreak outside of Africa, though, did occur in the United States in 2003 from pet prairie dogs that were co-housed with infected small mammals from Ghana. There were 47 cases associated with that outbreak. Going forward, cases continue to occur in Africa. The 9 African countries are the countries where we know that cases had occurred: Cameroon, Central African Republic, Cote d'Ivoire, the Democratic Republic of Congo, Gabon, Liberia, Nigeria, Republic of Congo, and Sierra Leone. In 2017, though, there was a large outbreak in Nigeria involving 17 states, and at that time it was considered a very large outbreak. It involved 138 cases. But during 2018 to 2021, there were imported cases in travelers from Nigeria to various countries. In 2018 to the UK and Israel, in 2019 to the UK and Singapore, and then 2021 there were 3 cases, 2 of which occurred in the United States. And then, of course, in 2022, a multinational outbreak occurred. So all of this is to say that, it does seem to be of public health significance and importance. There's been a lot of cases, and in recent years, there's actually been a reemergence of human cases after decades of no reported cases in some countries. So even before the 2022 multinational Mpox outbreak, investigations when there was a single case of Mpox have been intense. During the July 2021 investigation, one of the investigations in the United States, there were 223 contacts who had to be monitored. Fortunately, there were no high-risk exposures and there were no secondary transmissions, but there were a lot of contacts, including flight crew and fellow passengers on international and domestic flights, friends of the affected patient, and a rideshare driver, and all of these individuals were monitored by public health authorities. 2 imported cases that occurred to the United Kingdom, however, in 2019 and 2021 did result in secondary infections. In 2019, a healthcare personnel developed Mpox after presumed exposure while changing the bedding of an Mpox patient, and in 2020, 2 household contacts of an Mpox patient developed Mpox, so those were household contacts. And then, of course, we know from Dr. Ellington's presentation that this outbreak is obviously involved in many, many cases, which peaked in early August, and the case counts are decreasing at this time, but this outbreak is not over. The typical manifestation of Mpox during the current outbreak are small, firm, deep-seated, well-circumscribed lesions that can occur on the palms and soles and on other parts of the body as well. They've often been scattered or focused on one body part, most commonly the genitals. Prodromal symptoms, including fever and lymphadenopathy, have inconsistently occurred. When lesions have occurred in the periurnal or genital region, the pain from lesions has been particularly pronounced. Rectal pain, abdominal pain, rectal bleeding, and tenesmus have all been reported. But typically, symptoms resolve with supportive care alone, including pain control. However, severe manifestations are occurring in some patients, and those patients have very severe outcomes as well. So a warning, the next two slides are the two slides that have some graphic images, the second one in particular. So severe manifestations include ocular lesions, neurologic complications, myopericarditis, and certain mucosal lesions, and can affect patients regardless of the immune status. So myopericarditis cases we have seen in people who developed Mpox, not just in individuals. We talked earlier with Dr. Duffy about myopericarditis after vaccination, but this slide is referring to myocarditis after Mpox. The image on the top left shows keratitis and a conjunctival ulcer associated with ocular Mpox. Ocular lesions can be very serious, and they can even cause blindness, as they have in other countries where classic Mpox has occurred in Africa. Myopericarditis and neurologic complications have been reported in a small number of patients. We're uncertain of the reasons for this. It has occurred in individuals who have been immunocompetent. The bottom left image is an electrocardiogram from a patient diagnosed with myocarditis from Mpox. The right side of the slide shows radiologic images from a published report of encephalitis and transverse myelitis in a patient with Mpox. When lesions occur on certain mucosal surfaces, for example, the urethral meatus, the penis, they can cause complications including obstruction. The lesions can be severe and necrotic and require consultation from medical subspecialists, including urologists, gastroenterologists, and general surgeons, depending on the location of the lesions. So these are considered severe manifestations, but the most severe and the life-threatening lesions occur in patients with severe immunocompromise. And the next slide does show those graphic images that I mentioned. So patients who are severely immunocompromised due to advanced HIV in particular have had the most severe manifestations of Mpox during the current outbreak. The etiology is believed to be uncontrolled viral spread due to severe immunocompromise. The images on this slide show the progression of illness and illustrate how different the lesions in these patients can be from the typical presentation. Medical therapeutics, including tecovirimat and brincidofovir, may be helpful, but an optimized immune system through antiretroviral therapy or a temporary halting of immunomodulator therapies or some other mechanism is still the most critical aspect of care. And deaths have unfortunately occurred because of these illnesses, often weeks and weeks after hospitalization because of the progression, despite the therapeutics, which are not virucidal. So in response to the question, are outbreaks of Mpox of public health importance? Based on all of the data presented on these slides, the work group's interpretation was yes. Moving on to the benefits and harms domain, as Dr. Chard has already presented, there are early estimates and population-based estimates of vaccine effectiveness. Vaccine performance has been evaluated through comparison of incidence of Mpox between vaccinated and unvaccinated persons in 43 U.S. jurisdictions. Mpox incidence among unvaccinated was 7.4 times that among persons who received only one dose of JYNNEOS vaccine greater than or equal to 14 days earlier, and 9.6 times that among persons who received dose 2 greater than or equal to 14 days earlier. Population-based adjusted measures of vaccine effectiveness, or VE, using electronic medical records has also been performed and was presented by Dr. Chard. Two studies. A retrospective population-based cohort study conducted in Israel showed that 5 Mpox infections occurred among subjects vaccinated with 1 subcutaneous dose and 16 among unvaccinated subjects. The VE for dose 1 was calculated as 86% with the confidence interval of 59 to 95%. There's also been a nationwide U.S. case control study with a 1-to-4 ratio of cases matched to controls, and the adjusted VE was 35.8% with a confidence interval, 95% confidence interval, 22.1 to 47.1% for one dose, and 66%, 95% confidence interval, 47.7 to 78.1% for two doses, regardless of the vaccination route, so whether it was intradermal or subcutaneous. And then Dr. Chard also presented some population-based adjusted measures of VE using case control studies. The first was a case control study of adult MSM, 18 to 49 years of age, in 12 U.S. jurisdictions. The adjusted VE was 76% with confidence interval 48 to 89% for the two doses. And those are interim results. As she pointed out, the study is ongoing, and so we hope to have more information to present at the June ACIP meeting as well. And then preliminary results that are unpublished from New York State were also presented, a case control study of adult male Mpox cases matched to STI controls. The adjusted VE was 68% with the confidence interval 25 to 86% for one dose, and 89% with the confidence interval 44 to 98% for two doses. And again, those are preliminary. The analyses are ongoing. PEP effectiveness and infections following a single dose, Dr. Chard also presented information about that. So in France, 10% or 11 out of 108 subjects of those administered JYNNEOS after Mpox exposure became symptomatic with Mpox disease soon after vaccination. The interquartile range was 1 to 6 days, a median of 5 days, although the clinical course was mild among those persons. Also in France, there was an observational study involving people who received a single subcutaneous dose, and in there, 4% were infected during the month after the vaccination, and again, none with serious infection. And in New York City, there's a cohort study of individuals with high-risk exposure, and VE was 77% with PEP less than 14 days after the last exposure, and 79% with PEP less than 14 days after the first exposure. So, based on all of this information that seemed to support the benefits of the vaccine, the work group's interpretation of the question, how substantial are the desirable anticipated effects of Mpox vaccine during an outbreak, was large. The work group chose large. Vaccine safety I've focused here on the subcutaneous route of administration. During May 22nd, 2022 to January 13th, 2023, a total of 1,125,168 JYNNEOS vaccine doses were administered. CDC monitored JYNNEOS safety using VAERS and VSD for vaccine recipients of all ages, as Dr. Duffy explained. The most common adverse events reported were non-serious and included injection site reactions consistent with pre-licensure studies. These were reported at similar rates for doses received by intradermal and subcutaneous administration, and serious adverse events were rare among adults. So in response to the question, how substantial are the undesirable anticipated effects of Mpox vaccine during an outbreak, the work group's interpretation was small, since we're referring to subcutaneous in this question. So the balance between the desirable effects relative to the undesirable effects, the work group felt, based on the previous slides, that it favored the intervention, which is vaccination with JYNNEOS. Moving on now to the ETR domain values. As Dr. Delaney presented, there's been some surveys that we use to assess values of the individuals who are being vaccinated during the 2022 outbreak. So even though this vote is for Mpox outbreaks in general, that may not be specific to male-to-male sexual contact-associated spread, we do have that data from this outbreak to rely on to answer this question. So populations at highest risk concerned about Mpox in the August AMIS survey, 53.1% of respondents had concerns about getting Mpox. During October to December, an AMIS survey showed that those with high Mpox concern had 3.5 times odds of being vaccinated. Interest in the vaccine seemed to be high during August and November. Greater than 85% of respondents in the Amethyst survey were interested, study were interested in the vaccine. During August to December, 50% of Porter Novelli survey responders who identified as LGBTQ+ felt that the vaccination is important to protect from Mpox. That, of course, includes not just MSM, but other LGBTQ as well. And then during October to November, greater than 70% of MSM in a San Francisco survey of persons experiencing homelessness reported that they would accept or have accepted vaccination. And this is important because we have seen a disparity in that individuals experiencing homelessness have experienced a disproportionate number of cases, just as those who are Black and Hispanic have. So to answer the question, does the target population feel that the desirable effects are large relative to the undesirable effects? We have the data from this outbreak to tell us that probably yes is how the work group answered this, since we do not have data about every population. So there is some uncertainty or variability in how much people might value the vaccination. During the 2022 Mpox outbreak, willingness to be vaccinated was dynamic and dependent on perceived vulnerabilities. Clear demand for JYNNEOS vaccination occurred, but many still remain unvaccinated, and this is unclear at this time. Demographics of future outbreaks would also be unclear, which is why we believe there might be some uncertainty or variability. We do not know what the demographics of future outbreaks would mean, who the affected populations might be, and so it's unknown if the values expressed by the population most affected by the 2022 Mpox outbreak can be extrapolated to all other populations. And for this reason, in response to the question, is there important uncertainty about or variability in how much people value the main outcomes, the work group chose possibly important uncertainty or variability. Now, acceptability. So as Dr. Delaney already explained, the stakeholder perceptions are very important to this question. There is CIRMO, which is an online community of greater than 1.3 million clinicians. During July 31st to August 1st, 2022, there were survey results of U.S. clinicians from this, 415. 69% felt the U.S. Was without enough Mpox vaccine to handle the outbreak, indicating that they wanted vaccine to be available. And then September 12th, the survey done at that time among 62 U.S. clinicians showed that 66% had treated at least one Mpox patient, 76% knew where a patient could get JYNNEOS vaccination, and 86% wanted to be able to provide vaccination to their office. So taken together, the work group interpreted this as the clinician stakeholders being supportive of vaccination. Now, moving on to health departments and other community-based organizations, health departments have been requesting JYNNEOS and organizing vaccination campaigns. So you can see here on this slide some newspaper headings that indicated that health departments were receiving Mpox vaccine and were also setting up appointments for vaccination campaigns. And then in this screenshot from the HHS website, there's more information, but basically 70% of the allotted JYNNEOS vaccine doses have already been requested and shipped out to states, and so the requests are coming from stakeholders. In addition, the Vaccine Equity Pilot Program was something that, as Dr. Delaney explained, is something that has enabled jurisdictions to request more than their allotted amount of JYNNEOS vaccine. It was established to support innovative ways to address vaccination disparities, encourage vaccination coordination between health departments and community-based organizations, and promote innovation to strengthen existing vaccination infrastructure. 28 programs involving 15 jurisdictions and approximately 25,000 doses have been associated with the Vaccine Equity Pilot Program, and this is above and beyond the allotted amounts shown on the previous slide, all of which, again, is showing that among stakeholders, health departments, community-based organizations, there does seem to be support for the vaccine. And so, in response to the question, is the intervention acceptable to key stakeholders, the work group answered yes. Moving on to resource use. So JYNNEOS vaccine is provided from HHS's Strategic National Stockpile, or SNS, free of charge. Vaccines are a good use of resources during an outbreak, and this ETR and this vote is intended for outbreaks. However, costs and challenges, there are costs and challenges associated with mobile pop-up vaccination sites, and a cost-effectiveness analysis of vaccine implementation during the current outbreak is not currently available. As previous comments during previous sessions have indicated, it's sometimes perhaps not as efficient as we would like when coming from stockpiles. So in response to the question, is the intervention a reasonable and efficient allocation of resources? The work group was split on this. Some people felt that it was, everyone felt that it was reasonable, but the efficient part was uncertain to some individuals, and that's why the answer chosen was varies. Next, equity. So no groups or settings are disadvantaged by a recommendation for JYNNEOS use during Mpox outbreaks. Effectiveness is the same for all immunocompetent persons. Implementation definitely needs to be needs to assure equitable access. It'll be very important, particularly among persons who are at high risk for severe outcomes. The recommendation might facilitate, this recommendation by ACIP might facilitate broad acceptance of the vaccine, example by insurance companies and health departments, because it's an endorsement by ACIP after rigorous review of the evidence. And so interpreting equity as independent of implementation challenges, the work group felt that the impact on health equity was that it was probably increased. And then finally, the ETR domain about feasibility. So feasibility of conducting the vaccine campaigns in communities, at events, and within the public health facilities was demonstrated in this 2022 outbreak. Vaccinations can be integrated into providers' practices. There's standing orders available. Immunization information systems requirements for reporting vaccinations are the same as for COVID-19 vaccines. And the JYNNEOS can be stored refrigerated for 8 weeks. So perhaps all of these things facilitate the feasibility of vaccines and the vaccine recommendation. There is a wide range of vaccinators who can administer JYNNEOS, unlike the other orthopox virus vaccine, ACAM2000, which some clinicians are hesitant to administer. The work group thought carefully about this and felt that the JYNNEOS vaccination probably is sustainable during outbreaks. Vaccine access is an important concern. There needs to be increased and convenient access for all persons who might be at risk and in a low stigma setting. Considerations to ensure vaccine equity would be strong ties with community-based organizations, support for vaccination events, engagement of trusted messengers, and ensuring that there is access, including in rural areas. And so in response to the question, is the intervention feasible to implement, the intervention being JYNNEOS during outbreaks, the work group felt that the answer was yes. So just to summarize the responses to all of the ETR questions, you can see on this slide all of those responses, and perhaps the favorable side of the responses are shown in green, and red are the others. So is there important uncertainty about or variability in the values? The work group felt there was possibly important uncertainty or variability, mostly because we do not have data about stakeholders who might be affected during other types of Mpox outbreaks. We only have the data from this current outbreak. And then whether it was a reasonable and efficient allocation of resources, work group members certainly felt that it was very reasonable to have vaccines during an outbreak if it was going to prevent infections, which we know the Mpox vaccine does. There was some pause when it came to efficient allocation of resources. And for that reason, the answer chosen was varies. So the balance of consequences, after considering all of these responses, the work group felt that the desirable consequences clearly outweigh the undesirable consequences in most settings, and drafted the language on this slide for the consideration of ACIP. So ACIP recommends the 2-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of Mpox during an Mpox outbreak. Clinical considerations is something that we'd be certainly interested in hearing what ACIP members and others think about what should be included. In an outbreak setting, the vaccine is ideally given pre-exposure, but may also be given as post-exposure prophylaxis. The complete 2-dose vaccine series should be given regardless of the timing of the exposure, and that is what we had planned to put into the clinical considerations. And if there are vaccine supply shortages, the intradermal or ID route of administration can be used. We will be talking more about data about the intradermal route of administration at the June ACIP meeting. And of course, the MMWR that consolidates the entire outbreak language from this meeting as well as the June meeting will be consolidated into one MMWR after that. So ID data will be presented at that time. And then just as a reminder of our plans, I mentioned that the February and the June meeting will be about this. During the June meeting, we will provide updates about vaccine effectiveness and safety, and we will also have a separate vote for administration of the vaccine in people less than the age of 18 years. We are focused today on greater than or equal to 18 years, partly because that is simply an expansion of the 2022 ACIP recommendations for persons at occupational risk. It's the same age range, it's just to a different group of people. June, we will focus on individuals less than 18 years and updates. And then depending upon the epidemiology of this outbreak, if cases are continuing to occur and occur in large numbers, then during the October ACIP meeting, there will be more discussion and consideration for a longer term, even if it's short term, vaccination strategy with the 2-dose JYNNEOS series. And with that, I will take any questions. It's been a large group because this was a CDC response that the ACIP work was partly supported by, and so I'd like to thank all the people listed on this slide. Thank you.
Thank you, Dr. Rao. And I just want to commend the work group, Dr. Sanchez, Dr. Rao, and all the team members for a phenomenal job trying to get all of this in one session, but I think you did a wonderful job putting together the evidence, and it was actually an incredible amount of evidence, to be honest. So I'm duly impressed. This presentation is now open for questions. Dr. Lehrer.
I want to second the thank you for all the hard work and the excellent presentations. I have a couple of comments and then one question. I'm fully in support of the recommendation. When I look over the entire picture, this is a common disease. Even now at its lowest, we still have 2 cases per week, which is higher than we had per year in the past few years. We have a very effective vaccine. We've got good data on that. We often don't have good data on that. And it's actually got a fairly high death rate. If I'm doing my math correctly, it's about 1 in 1,000, and that's not an insignificant death rate. So I'm very much in favor of this. I have one question with sort of an international perspective. We have a lovely graph that shows a decline in the number of cases and corresponding to the number of vaccines that we were given. And I'm wondering if we can have a perspective of places where the vaccines weren't given. Did the cases also decline across the world, or is that really, can we infer that the vaccines might have actually made that decline happen? Thank you.
I can partly answer this question. I guess we think that the vaccines have had an impact, as have behavioral changes, but it's true that in countries where there is no vaccine available, case counts have also decreased in many of those countries. So perhaps this is a little bit more complicated, but vaccines certainly are having a role.
Dr. Cotton.
Thanks very much for all the amazing data that was presented. I think we're still lacking significant information for immunocompromised patients. And I was wondering, when we're looking ahead towards the October meeting and thinking about additional doses, it seems like in general, for many vaccines, immunocompromised patients do need additional doses. Will there be any specific focus? I do understand that, there's sort of the bigger question, but I'm wondering if there'll be any focus on immunocompromised patients who might benefit by an earlier additional dose of vaccine. Thank you.
Yeah, it's a very good question. We are collaborating with some other partners to try to do some immunogenicity sort of studies to try to understand the role of immunocompromise, and do plan on discussing that within the work group. And we'll certainly, we've had clinicians on our work group who have also brought up this same concern because they care for patients with advanced HIV, but also with other reasons for immunocompromise, transplant patients and others who are at higher risk, and so we will certainly discuss it more and bring any new data to the ACIP.
Any other questions in the room? Dr. Daly.
Yeah, thanks so much. So Dr. Rao, this is sort of picking up on comments that Beth Bell made earlier. Can we continue, or in what way can we continue to work on sort of lessons learned for sort of the next outbreak? And I guess I would highlight a couple points here, which is that if we have a risk-based recommendation, access is limited, and then those risk factors are stigmatizing to some extent, then that is going to present these inherent challenges that are going to keep coming up if it's Mpox in the future, or if it's another infectious disease that has those similar characteristics. And education helps, but it's not going to solve that problem to the extent that somebody who isn't aware that they're at risk then needs to be seen in a clinical setting, and then risk needs to be assessed. So I guess the bigger picture for me is sort of what extent of community engagement can we think about now for future outbreaks, particularly future outbreaks that have those similar characteristics? Thank you.
Yeah, no, thanks, Dr. Daly. Those are certainly really important things that ACIP needs to consider and that we've been grappling with as well. I wonder if Dr. Carter, if she's still on the line, if Rosalind, if you might want to say anything about the interim clinical considerations and the fact that as much as possible, individuals should not have to explain their reason for the vaccination. There's wording there to indicate that. And also the work group themselves, we discussed, whether, if someone's a household contact of someone who has high risk and is refusing to be vaccinated or whatever else, that they should be able to get vaccinated as well. And so there is that permissiveness. I mean, if individuals feel that they're at high risk, they should be allowed to, and there should not be the stigma associated with it or an explanation for why they consider themselves high risk. Dr. Carter, do you want to add anything since you were one of the leads on some of the drafting of that language?
Sure. I think to address that question, I'd probably also add that there is as others have mentioned, there is a need for continual community engagement and education in this area, particularly as the outbreak has faded somewhat and it's just not top of mind, not covered well in the media, et cetera. So I think there are, a number of things that we can continue to do to sort of keep this in the public eye. We are engaging in a lot of work around Pride events in the spring and working with states and with community partners through some grants through CDC Foundation as well, that is very much sort of grassroots, providing education ahead of time to encourage vaccination, to make sure people know where vaccines are still available in the community, but agree that there's that continual need for education. And then just in terms of sort of not having to attest to being part of specific groups, I think we've learned over time that there are many disproportionately affected groups that also don't like to label themselves in particular ways. And so again, keeping that eligibility criteria broad so people understand what the risk factors are, but they don't have to necessarily attest to engaging in specific activities or labeling themselves in ways that could be stigmatizing.
Thank you. Dr. Brooks?
Yes, excellent presentation. So has there been any consideration or thought to the concept of outbreak, especially on a geographic or geopolitical?
Dr. Brooks, so sorry. Could you get closer to the mic? We're having trouble hearing you in the
Sorry, can you hear me now?
Yes, that's much better. Thank you.
Oh, yeah, thanks. I'm closer to the mic. So have you given thought to the geographic or geopolitical aspects of what is considered an outbreak? For example, if one county determines that there's an outbreak, one state, one region, national, and how what someone determines to be an outbreak, and perhaps there are certain areas where there's no, there's a political aspect of saying we aren't going to call this an outbreak. So you say public health authorities, excellent. So it could be city, county, state, national, or any other designation.
Yeah, that's correct, Dr. Brooks. So you're right, there could be any number of, an outbreak could look different in so many different ways. And so, yes, local health departments, state health departments, federal can all make that determination of what is considered an outbreak. If there's a single case in the, the United States from a traveler, then that might be enough. That is enough at this time, and it was enough in 2021, it would be enough. And then there's also, as we mentioned in this footnote here, there are other circumstances in which a public health response could be indicated, including ongoing risk of introduction of Mpox into a community because there's activity in another geographic area. So it is pretty broad, and it would, public health authorities would make that decision at the time of an event.
All right, thank you.
Dr. Sanchez?
I just want to thank Dr. Rao, and really, she's an amazing effort. I don't want to add too much uncertainty, but I think the clinical considerations, we also will need to discuss booster dosing. I know that that's still, and maybe she can comment on that as well.
So because these are outbreak recommendations, so we think that they would be in effect like for a finite outbreak. But if there is a longer term recommendation, then booster recommendations obviously become very important and will be part of our work group discussion. So it won't be part of what we discussed before June, but will be after June. In case it's helpful, I mean, we get this question often, people wondering whether someone who recovered from Mpox should get vaccinated, and currently we're not recommending that. We think they'll have protection from their natural illness. And then in case it's helpful, during the 2020 ACIP meetings, we did present information in the grade tables that indicated that there is an anamnestic response at least 2 years after the two-dose primary series. And so we assume that similarly, there will be at least 2 years, and the reason we do not have data beyond 2 years. So we do have a study that we are conducting in the Democratic Republic of Congo to try to understand booster doses beyond 2 years. It's in progress, actually, where we administered boosters 5 years after to understand the immune response, and we hope to have more information from that, as well as other collaborations over the coming years that will inform recommendations about booster doses. Thank you, Dr. Sanchez.
Thank you. Ms. McNally?
Thank you. Can you just comment on what the clinical guidance will be relative to receiving this vaccine along with other vaccines?
Yeah, so again, the 2022 ACIP recommendations that were published about JYNNEOS, we did include verbiage that indicated that for individuals who are at the highest risk for myopericarditis after the COVID vaccine, that they might consider not receiving them concurrently. And I think that language is also reflected in the COVID recommendations and online, but we do not have concerns for co-administration with other vaccines, and so there is no other cautionary messaging. So we will work very closely with our colleagues in CDC's vaccine safety, as well as with the COVID work group to see what they currently recommend, what data they have currently to make any updates to that language. That's the only language we currently have about co-administration with other vaccines.
Thank you.
Thank you. Dr. Paling?
I wanted to add my voice of appreciation for how much information has been pulled together and shared so coherently. and agree with what has been said. I also am humbled by the fact that in the last 20 years, we've had multiple outbreaks here in the United States. And with that, and with recognition that over 1 million doses of JYNNEOS have been administered, I wonder if it would be wise to follow long-term serologies and seeing how long that immune response persists. I know we don't have data beyond 2 years, but if I'm thinking ahead, people who are at risk today may be at risk in 20 years. And so that way we could be hopefully ahead of the game for a future outbreak. Thank you.
Thank you.
Thank you. I see Dr. Han's hand raised.
Hans again, thank you. Yeah, I just, Chris Hahn representing CSTE, just wanted to kind of go back to Dr. Brooks's question, which is a great one about the kind of the vagaries of declaring an outbreak and sometimes political considerations and that type of thing. But it is a complicated, messy process, and but state and local public health does this, all the time for all sorts of diseases, including other vaccine preventable diseases that change vaccine recommendations like mumps outbreaks and measles outbreaks. I know everyone's aware of this, but I do appreciate this language because I think it does give us a lot of flexibility to implement more aggressive, if you will, vaccination measures when we feel it's needed. So I think I speak for state health departments, at least in saying we do like this type of broad language that would give us that type of flexibility.
Thank you. I am just going to state that I endorse the proposed wording of the recommendation on the slide, and if there's any other questions or comments from my fellow ACIP members, please feel free to raise your hands while I do have the floor. There's one other area that I think it would be really helpful for this work group, and to be honest, all of our vaccine work groups to consider regarding implementation. So I was really impressed that you said you captured over 90% accurate data on race ethnicity. It's really hard to capture that data accurately, so that's actually a really excellent outcome to be able to ensure that we have that information. I will add that many of our health systems are also capturing information on preferred language, as well as disabilities, to be able to continue to enhance our access to ensure that we are thinking through the implementation considerations and enabling equitable access to vaccines or other health interventions. So it may be that as our health systems are doing that, and it is becoming a joint commission requirement, that it would be great to have our clinical trials always have that information available, clinical studies, and then thinking through surveillance systems and what opportunities are available to capture that information. Thank you. I don't see any hands raised in the room or on Zoom. Oh, thank you. It's been so long. It's been a whole, what has it been, 4 months? 4 months. So I've forgotten about the motion. I'd like to ask if any of our members would like to make a motion.
So this is Dr. Lair. I make a motion to approve the recommendation as stated on the slide above. Thank you.
Thank you. Dr. Paling?
I'd like to make a second.
Thank you. So it's been moved and seconded that we accept the proposed wording on the slide that ACIP recommends a 2-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of monkeypox during a monkeypox outbreak. And with that, I'd like to thank our presenters and actually suggest that we now recess until 12:30 p.m. Eastern Standard Time.